keep discussion for last few talks only, right?
Hmm.
Yeah,
Okay.
sure.
Any doubt, you ask the students to put it in the group. You know,
Hmm.
we'll answer that subsequently.
Okay.
All
Okay,
right.
but if stretches beyond 9, no, then students also they don't have the patience. Sharik, are we live? Chalo, live command do.
Yes, sir, you're lying.
So, good evening, everyone. So, welcome to our third module. And today we are going to have our glaucoma module. And this is very important because glaucoma module, you will get long cases, short cases. Also, in theory exam, also you may get your essay type of questions and short answer type question. And in practical, also, it's very important. Why? Because they may be keeping some drugs, keeping some instruments. So, all in all, glaucoma is very important for postgraduate students. And also, once you clear your PG, you know that glaucoma is a day-to-day problem that we'll be dealing with. So today we have an excellent range of speakers to take care of today's module, and we have Dr. Talvir Sidhu and Dr. Karthike for moderator, and two more moderator will be joining soon, I guess. Karthike. So I hand it over to Karthike and Talvir. Please take forward this session.
A very good evening to everyone. Thank you, Dr. Praful, for this wonderful organization of the PG crash course, which is necessary for the PG learning, and it's a real crash course where you learn everything in 7 days. Now coming back to our session, so this glaucoma session will have 14 talks, and the chairpersons are Dr. Purvi Bhagat, ma'am, Dr. B.N. Gupta, and Dr. Pranav Ranjan sir. So the first talk will cut short to the talk. So the first talk is glaucoma classification and workup by Dr. Narayanan. To Dr. Narayanan, please.
Is my screen visible to everybody now?
Yes. Just started sharing. So
I've shared it. You can. Okay. Is it visible, the presentation?
yes, your
Yes,
presentation is
sure.
visible.
Good evening, everybody. At the outset, I'd like to thank the organizers for giving me this opportunity to talk about approaching a case of glaucoma. As Sir had mentioned, it's a very important exam case for all postgraduates. So I'll give you a few tips on how I would go about a case with a clinical example as well. So glaucoma, as you all know, is a chronic progressive optic neuropathy with optic nerve changes, visual field changes. IOP is a modifiable risk factor. So the age-old classification is always given us on the basis of etiology as primary and secondary, and the basis of the anterior chamber anatomy as open angle and closed angle. And of course, on the basis of onset as an infantile, juvenile, or an adult onset glaucoma. So when we look at the pathophysiological classification, we've seen it as primary and secondary glaucoma, and especially if it's a secondary glaucoma, we look at the cause of the glaucoma. So if there is an open angle, then if it is either because of a pigmentary glaucoma, exfoliative glaucoma, lens-induced glaucoma like a phacolytic or a phacoanaphylactic, or if it is a steroid-induced glaucoma. And if it's a closed angle, if there is a pupillary block or a non-pupillary block. And if it's a non-pupillary block, if it is an anterior pulling mechanism or a posterior pushing mechanism, like in neovascular, eye syndrome, aqueous misdirection, etc. So with this understanding, it is always essential for us to look at how the patient is presenting to us. So while taking a history, always look at the route of referral. If the patient is asymptomatic, if the patient is being referred by another practitioner, or if he has come for a general checkup and it's an incidental finding of the glaucoma, or if the patient is coming to you for screening due to the presence of a positive family history. If the patient is symptomatic, look for signs of vision loss and pain. And if they are follow-up patients, always look at the entire record of the patient as they have presented from the initial finding onwards. Your history taking should always be directed towards looking at risk factors, not only for the diagnosis, but also the prognosis of the glaucoma patients, and to be managed effectively in the course of the disease. So here's an example of a 52-year-old male who came to the OPD with diminution of vision in both eyes for about a year. He was already established POAG, referred to us, with a baseline IOP of 38 and 32 millimeters of mercury in both eyes. The baseline HVF showed a right eye nasal step and left eye had an advanced field loss. Patient was on Combigan. Always make sure you don't use only the trade names, but also elicit the drugs if the patient is showing you the bottle, and on Travoprost on and off. In his past history, he had no use of steroid, no trauma, bronchial asthma, sleep apnea, and he was a known diabetic for 20 years on treatment. He was not a known hypertensive. There was no family history of glaucoma. On ocular examination in the right eye, the visual acuity was 612 with pinhole improving to 6.9. The anterior chamber was normal. The pupil was brisk and reacting to light. The IOP with Goldman applanation tonometer at 11 a.m. was 44 millimeters of mercury, and the gonioscopy with classified according to the modified RP Center classification with a 4-mirror Sussman lens was open in the right eye. The left eye was also similar, except that the pupil showed a sluggish reaction and the presence of an RAPD, and the IOP at presentation was about 42 millimeters of mercury, and gonioscopy was also open. While looking at the fundus of the patient with a 90D lens through slit lamp biomicroscopy, it was an average size disc with a vertical cup disc ratio in the right eye of about 0.9:1 with bipolar thinning. The presence of bearing of circumlinear vessels was there. There was also a superior notch, and the left eye showed an average size disc with vertical cup disc ratio of 0.95:1 with neoglaucomatous optic atrophy and pallor, which was correlating to the RAPD as well. The pachymetry was 555 in the right eye and 540 in the left eye. The visual fields are enclosed, as you can see in the right eye, and it has progressed in over a period of time over the next 4 years. So my diagnosis is both eye primary open angle glaucoma with right eye advanced glaucoma and left eye severe glaucoma approaching glaucomatous optic atrophy with IOP not in target. So since HVF showed progression management initially restarted for the patient as he had stopped all his medication. So he was started on all the drugs that he was using before he was lost to follow-up. After that, when he was followed up, the IOP, despite maximum medical therapy, was not in target. Since HVF was worse in the left eye, the need for trabeculectomy with mitomycin C in the left eye was explained because the visual field was worse in that eye to the patient and the attender. So through this history and the clinical example I've shown, the various things that we have looked at are the risk factors in glaucoma, which is the age, the race of the patient, presence of family history, the presenting features, which include the intraocular pressure, optic nerve. Always look for a history of myopia, especially in open angle glaucoma, the central corneal thickness, and systemic risk factors like diabetes, hypertension, and iron ocular perfusion, which I will be discussing as we're going along. The use of corticosteroids has to be elicited in all patients, not only in topical form, but also in the form of ointments, creams, nasal sprays, oral tablet, and any other medication, especially if the IOP is high. Ocular perfusion is now become a very important entity, especially as the paradigm has shifted in towards normal tension glaucoma, especially with low diastolic perfusion pressure. So nocturnal hypotension is looked at as a very close entity in NTG. So you also, when you are looking at history taking, look for beta blocker use at night, which can mask the effect of topical medication. Also, antihypertensives at night can reduce blood pressure and in turn reduce the ocular hypoperfusion and also cause disease progression. If the IOP is controlled and there is still disease progression, look for a history of obstructive sleep apnea, carotid occlusion of any kind, prolonged breath holding, hyperventilation, kapabhati, and the use of lifting heavy weights and playing of wind instruments, including Shirshasana in yoga. As we had seen in the example, always in your examination has to use visual acuity, the best corrected visual acuity, extraocular movements, pupil, slit lamp biomicroscopy, IOP measurements, gonioscopy, which will all be discussed in detail in each of these tasks. So a pupil examination, you can look for RAPD, which is also diagnostic and prognostic factor, look for signs of angle closure, neovascularization, etc. And when you are doing a slit lamp examination, make sure you look at other signs of secondary glaucoma, which include pseudoexfoliation, pigment dispersion, the Krukenberg spindle, telltale signs of uveitis, history of old trauma, and if there is any kind of posterior synecdoche. If there is a presence of a bleb, always make sure that you grade the bleb when you are discussing it. So either you classify the bleb on the Moorfields classification or the Indiana classification, which will include the height of the bleb, the extent of the bleb, vascularity in the bleb, and the presence of any leaks or not. The intraocular pressure has to be done with Goldmann applanation tonometry. Always make sure you mention the time at which it is taken. In special conditions, of course, you can use the use of other devices like tonopen can be elicited. Central corneal thickness has been looked at as a very important risk factor for the progression of glaucoma, especially in the OHTS and in many other population-based studies. So always mention the central corneal thickness. And always explain the Van Herrick's grading, because that will give you an idea if there is going to be a sign of angle closure. Gonioscopy is essential in all patients with glaucoma, all glaucoma suspects, and at every visit when these glaucoma patients present to you. The ideal testing conditions are very, very important for gonioscopy. And gonioscopy not only tells you about open angle or angle closure, it is also going to give you the causes of secondary glaucoma as well. Optic nerve head evaluation is very, very essential. So I would look at it as the 5 R's in assessing the disc. So observe the scleral ring, look at the size of the scleral rim, examine the nerve fiber layer in great detail, look for the region of peripapillary atrophy. So if there is a beta zone damage, then that is more essential for glaucoma. And always look for retinal hemorrhages and optic disc hemorrhages, which has been looked at as a very important cause of progression of glaucoma. Visual field is currently the gold standard program is the 24-2 CETA test. It has to be done in all cases of glaucoma, or if there is any chance of in a glaucoma suspect. So a single field is not sufficient, and a serial of visual fields are essential for understanding progression and also the impact of treatment. So it must never be interpreted in isolation. Field should always correlate with the structural changes in the disc. If structural damage is present but visual field is normal, repeat the visual field. If the visual field defect is present but there is no structural damage, then re-examine the disc. Always look at the reliability indices of the patient. Always demonstrate a repeatable functional defect, especially if you're planning any type of surgery or if there is any change in the medical management of the patient. Always take multiple visual fields, especially 6 to 7 visual fields in the first 2 years, to look for fast progressors, and also make sure that you take a visual field in all cases, because even a normal baseline is still a baseline, and always look for a learning curve. Over a period of time, a glaucoma progression analysis can also help in understanding. So each time you plan the surgery, post the surgery, get a new baseline for not only for understanding the disease, but also medical legal purposes. Finally, preperimetric glaucoma is also very essential part. So if there are no glaucoma disc changes, and if there are disc changes but the fields are normal, then you have to do an OCT imaging where you look at the OCT RNFL, you look at the GCC IPL, etc. And always make sure you set a target IPA before you start the treatment of the patient. So look at the age, vertical cup disc ratio, pattern standard deviation, presence of CCT, and baseline IOP. I'd like to conclude by finally with my last slide, where if you're looking at a patient with suspected glaucoma, slit lamp examination, IOP management, and gonioscopy is essential. If there is a raised IOP, then you're looking at if there are visual field changes or disc changes. If there are none, then it's ocular hypertension. If there are no visual field changes, then it is probably preperimetric glaucoma. And with visual field defects and RNFL defects, then you are looking at an open angle glaucoma. Always do a CCT in all cases, and and before you come to a diagnosis of NTG, make sure you do a diurnal variation test. Thank you.
Thank you, Dr. Narayan, for this wonderful presentation. I can see that our esteemed chairperson, Dr. Pranav Ranjan, is here. Sir, would you like to comment on this presentation before we continue to the next? Sir, you are mute.
Extremely informative presentation. He has covered almost everything. I'd just like to add a couple of points. In preperimetric glaucoma, electrophysiological tests, that also holds some ground, like pattern electroretinogram, that can give you a change almost 7 to 8 years prior to changes in the structural structure. Secondly, the color vision, the contrast. These are also two important aspects that can give you some clue in the preperimetric stage. These are the two things I would like to add. Three couple of things. Rest of the things he has covered very nicely. Thank you.
Thank you.
Thank you, Dr. Narayan. This was a wonderful presentation. You covered almost everything, how to go about a workup. Now we'll go to our next presentation, Gonioscopy by Dr. Piyush Ramawat.
Good evening, everyone. Thank you to the organizers for giving this opportunity. I hope my screen is visible now.
Yes, yes, it is visible.
Okay. So, gonioscopy is a very important investigation in case of glaucoma. It is very important in examination also, because in all cases of glaucoma, we need to do the gonioscopy. It is also asked in a theory examination. So, what is gonioscopy? It's a clinical biomicroscopic technique of examination of angle of the anterior chamber of the eye with the use of special contact lens known as gonioscope. Indications: there are diagnostic and therapeutic indications. Diagnostic indication, of course, we want to differentiate between open and close angle glaucoma. If it is close angle glaucoma, whether it is appositional closure or synechial closure, and if it is synechial closure, then the extent of the synechia. We also want to know any abnormal content in the angle, any neovascularization, pigmentation level. We want to also confirm in post-operative cases, patency of internal ostium of trabeculectomy, glaucoma drainage devices. These were the diagnostic indications, and in therapeutic indication, which are increasing nowadays with the advent of MIGS, we use the gonioscopy for various MIGS procedures, Kahook blade, bang, GAT. It is also used for lasers like laser trabeculoplasty. So why do we need gonioscope? We need gonioscope to negate the factor of total internal reflection. Normally, because of the tear film and air interface, the light rays coming from the angle get internally reflected, and the critical angle being 46 degrees. So now we change that this tear film air interface form to tear film gonio lens interface, and by which we are now able to see the structures in the angle. Types of gonioscope: mainly direct gonioscope and indirect gonioscope. Direct gonioscope, as name suggests, we examine the same quadrant, and in indirect gonioscope we are examining the opposite quadrant. Direct gonioscope, there are various types of direct gonioscopes. Importantly, at the PG level, you remember Cope's gonioscope, where you can examine both the eyes at the same time with the operating microscope, and more popular nowadays, Swan-Jacob gonioscope, where you do the various MIGS procedures. Indirect gonioscope, remember one thing, they are of two types. First one is a scleral gonioscope. Commonly used Goldman gonioscopes are the scleral gonioscopes, and corneal gonioscopes. Corneal gonioscopes includes Zeiss, Posner, Sussman. Sussman is a handle-less 4 mirror, and Posner is with the handle. These are the corneal gonioscopes. While doing the gonioscopy, remember it should be done after the tonometry, and the beam of light should not pass from the pupil because it will cause miosis and iatrogenic widening of the angle. Goldman scleral gonioscope will need a coupling agents like methyl cellulose, CMC. This will be coupling agents will be needed in a scleral gonioscope, but corneal gonioscope will use tear film as a coupling agent. While cleaning the gonioscope in between the patient, you can clean it with the mild soap and water. While for disinfection, you can use 70% isopropyl alcohol wipes, 2% glutaraldehyde for 20 minutes, or 10% bleach for 10 minutes. Dynamic gonioscopy, important question, can be asked in Viva, can be asked as SAQ also. So dynamic gonioscopy, indentation gonioscopy is done with the corneal gonioscope. Here we indent the center part of the cornea, and the aqueous get pushed out towards the angle. So in case of oppositional closure, because of this aqueous getting into the angle, there will be a widening of the angle. Here on the left hand side, on the right hand side, you can see the open angle after the indentation gonioscopy. And with the scleral gonioscopes, we can do the dynamic gonioscopy by manipulation. Here we will ask patient to look in the direction of the mirror, and we will have a widened view of the angle. Of course, if the commonly used Goldman indirect gonioscopes, we will get the opposite view of the angle, opposite quadrant we are examining. This everyone know, you can remember the mnemonic, everyone know the mnemonic also. I can see the sky, structures normally visible in the angle of anterior chamber, iris root, ciliary body, band, then the scleral spur, then the PTM, and then the Schwalbe's line. So main important thing, sometimes if the angle structures are not clear, you can go for the corneal wedge. Here we incline a thin bright slit of light about 15 to 20 degree, and you will get a two separate corneal reflections, one from the outer cornea and one from the inner cornea, and where they intersect is the actual Schwalbe's line location. So here there is a pigmentation, and which is, we can get confused with the PTM band with this pigmentation, but on doing the corneal wedge technique, this intersection line is coming at this pigmentation level only. So this is not the PTM, the Schwalbe's line should be here. So features to be seen in the gonioscopy: angle structures in the primary gaze, level of the iris insertion, iris configuration, width of the angle recess, degree of pigmentation, areas of iridotrabecular apposition, areas of iridotrabecular synechia, blood vessel, any other abnormal content. Most importantly, during your exam cases, you will be required to differentiate between this is an open angle on your left hand side, and this is a close angle on the right hand side. Here all the structures, ciliary body band, scleral spur, and the trabecular meshwork is visible. On the close angle, none of the structure is visible. In same quadrant also, on the left hand side you can see the scleral spur is visible, but on the right hand side it is obscured by the broad based synechia. These are the goniosynechia. Here you can see the goniosynechia. You need to differentiate between the iris processes and the synechia. Iris processes will be fine. They will follow the concavity and don't block the view of underlying structures. Whereas synechia are broad and they bridge the angle and obscure the view. This is a double hump sign or sine wave formation seen in case of plateau iris syndrome. Center hump is because of the lens and peripheral hump is because of the ciliary body. This is a salt and pepper appearance because of the deposition seen with the pseudo exfoliation syndrome. Sampolysis line, a pigmented line ahead of a Schwalbe's line. Sampolysis line commonly seen in case of pigmentary glaucoma and a pseudo exfoliation syndrome because of the increased pigmentation. This is a concave iris configuration. You need to also look for the iris configuration, and here we have a concave iris and with the increased pigmentation. So this denotes a pigmentary glaucoma. You need to grade the pigmentation. Grade 3 and grade 4 increased pigmentation will be seen in pseudo exfoliation and pigmentary glaucoma. Blood in the anterior chamber, this reddish discoloration can be seen in the hypotony also with the increased pressure of gonioscope and hypotony also, and there are various other causes. So you need to see, should be able to identify this also. Carotico-cavernous fistulas, superior vena cava syndrome. Then the blood vessels in the angle, the normal vessels and the abnormal vessels. The abnormal vessels will have a aborigine appearance. They will be fine abnormal vessels, whereas the normal vessel, they will be a broad, a single vessel. The normal vessels usually will not cause the scleral spur. Post-trauma, irregular widening of the angle recess, irregular widening of the ciliary body band will denote angle recession. But make sure you are examining all the quadrants and both the eyes, because regular widening can be seen in the myopia. So irregular widening of ciliary body band, angle recession. And in cyclodialysis cleft, you will have an increased gap between the scleral spur and the ciliary body band. Trauma, you can see the foreign bodies, blood clots in the angle. After the surgery, sometimes you can see a lens matter in the angle, lens haptic captured in one of the patient, various tumors, cysts. And this is important. In case of thickened anteriorly placed lens, you will have a pupillary block mechanism and a volcano-like appearance. So this is known as Mount Fuji's sign. Thickened anteriorly placed lens, Mount Fuji's sign. Aniridia, you will get a rudimentary iris stump. In Axenfeld-Rieger syndrome, there will be anteriorly displayed Schwalbe's line with the synechiae iris attached to it. In eye syndrome, iridocorneal endothelial syndrome, iris nodules will be seen in Cogan-Rees syndrome, and broad high pass in case of essential iris atrophy. Along with the broad high pass, there will be iris atrophy in essential iris atrophy. Silicone oil commonly seen after the vitreous surgery in superior angle. Then trabeculectomy, it is important to do the gonioscopy to know the patency of the ostium. It is patent here. It's closed by the iris, and after the laser, you can again reopen the ostium. Patency of the various implant, here the RD implant can be seen, which is patent. Swan-Jacob lens direct gonioscope is used for various MIGS. Here the bang is performed. There are various grading system for the gonioscopy. Commonly used is the Schaeffer's system. Schaeffer's system divide it from grade 4 to
Dr.
grade 0.
Piyush, please conclude in 1 minute. 10 minutes are over.
Okay, so the grading system there are various grading system, but most importantly, you need to document the posterior most angle visible. So if you are able to see the scleral spur in superior and inferior quadrant, just write SS, and the any abnormal structure with the synechia are visible, so you will draw the synechia or write there. So most posterior structure visible, write down that thing. Ideal way is to draw a Baker's goniogram where the center line denotes the scleral spur and the outer is Schwalbe's line, and there are various markings, there are various notations by which you can denote the blood vessel, blood, and various structure depending upon their position also. OCT, the gonioscopy has advantage that it can detect the cause also, pigment dispersion, angle, neovascularization, and 360-degree assessment is possible. For exam point of view, you need to remember definition of gonioscopy, indications of gonioscopy, types of gonioscope, what are dynamic gonioscopy, angle structure visible in the anterior chamber angle, pathological angles, Baker's goniogram, gonioscopic grading, and comparison. I once again thanks organizers, and I hope that was clear. Thank you once again.
Thank you, Dr. Piyush. This is a very big topic to finish in 10 minutes. In fact, all the topics are huge to finish in 10 minutes. Pranav Ranjan sir, would you please like to comment on his presentation?
No, he has covered almost everything. Just one point I'd like to add. The dynamic gonioscopy, right? That is important because when you are doing a PI, laser PI, that becomes important because you have to differentiate between a synechial closure and a appositional closure. If there is a synechial closure, the PI is not going to work. If there is a appositional closure, which you can find out with a dynamic gonioscope, then the PI is going to work. So this is very important. And I think this question is asked in many a times. So this is one aspect I would like to add.
Yes,
Thank
rightly
you,
said,
sir.
sir.
Thank you for
Thank
the
you.
wonderful comment. So now moving on to the next topic, it is optic disc evaluation by Dr. Deepika Sumant. Please welcome Dr. Deepika, and you can start your presentation. Also, please stick to the time.
Yeah. First thing first, thanks for the opportunity, Dr. Prafulla, Dr. Madhuvanti, and the organizers. I'm sharing my screen. Is my screen visible? Hello?
Not yet, not yet.
But, sorry. Sorry, I'm not able to.
You're not able to share. Can we take your talk a bit later? Can we go to the next talk?
Yeah.
Is Parul ma'am? Next is OCT. Dr. Madhavi ma'am is already
Yeah.
here. Ma'am,
Yes.
most welcome to the session. And can we
Thank you.
please take your talk right now?
Yeah, sure. I'll just share my screen.
Ji, ma'am. So I welcome Dr. Madhavi R. Pillai. She's a senior ophthalmologist. Now she'll be talking on OCT in glaucoma. We'll take optic disc evaluation after this talk.
Is my screen visible right now?
Yes, ma'am. Yes, ma'am.
Yeah. Good evening, all, and thank you all for the opportunity. Thank you, Dr. Prafulla sir, Dr. Madhwanti, and the entire organizing team for giving me this opportunity. So today I'll be speaking on OCT in glaucoma, which is once again a very high yield topic, especially when it comes to exam practical point of view also. So is my slide moving? Yeah. So glaucoma is characterized by chronic optic disc neuropathy, which is characterized by optic disc changes along with structural changes and functional changes in the form of a visual field changes. So the point you have to note here is this may or may not be associated with the raised intraocular pressure. So when it comes to structure versus function, this is one of the important points that you have to note is that the RNFL changes start way before the visual field changes starts to appear. That is the window period of at least you are going to have a 6-year window period. So approximately 50% of the RNFL loss is needed to detect even a small visual field damage. So there lies the importance of OCT evaluation. So for simplifying point of view, the OCT actually looks at 3 important things. One is the optic nerve head, second is the parapapillary retinal nerve fiber layer, and third is the macular ganglion cell. So my entire talk will focus and classify based on these 3 things. OCT is a non-invasive method, and this particular point you have to remember, it is based on low coherence interferometry. It gives high resolution and cross-sectional images, and the OCT scan will be over within a matter of few minutes. So broadly classified, it can be classified into the time domain as well as the Fourier domain OCT. So under the Fourier domain OCT, you have the spectral domain OCT and the swept source OCT. So what exactly is the difference is that the time domain has a movable reference mirror. When it comes to the Fourier domain, both have the fixed reference mirror. However, the difference between the spectral domain and the swept source is the source of light. Here you have a broadband light source, whereas here you have a swept source. So today's talk, I'll be showing most of the printouts related to Cirrus HD OCT. If time permits, I will touch briefly upon the Spectralis OCT by Heidelberg also, no financial disclosures. So these are the various printouts from different machines, Zeiss, Optoview, Topcon and Heidelberg. Essentially, all look at 3 things, that is the optic nerve head, the parapapillary retinal nerve fiber layer, as well as the macular ganglion cells. So let us look at the retinal nerve fiber analysis. So this is the calculation circle that is being done for the OCT. So the 3.4 millimeter diameter circle. Inside this, all the calculations of the retinal nerve fiber layer happens. So why this 3.4 millimeter diameter is chosen? Because retina at this area is mostly nerve fiber layer, and it is large enough to avoid the edge of the optic nerve head and also avoid the areas of peripapillary atrophy. This is measured in a clockwise fashion in the TSNIT pattern. So this is one of the graphs I'll be showing. So it is measured as clockwise from temporal, superior, nasal, inferior and temporal. Another double hump pattern is in OCT. So why this double hump occurs? Because the superior as well as the inferior quadrants are the thickest in OCT. So next is a neuroretinal rim. So once again, this purple indicates your calculation circle. So this black is your disc margin and this red is your cup margin. So where exactly is the neuroretinal rim is between the disc margin, that is the black circle, and the red circle, that is your neuroretinal rim. So let's jump into the interpretation part, which is going to be most important for your practical. So at the start, you look at the date of birth as well as the signal strength. Why this is very important? Because the date and the name, because it is related to the age match normative database. So quality of the scan is determined by the signal strength. So one has to remember this varies from machine to machine. For size-less OCT, the operator, that is, they give a value of more than 6 should be there. If it is less than 6, you are going to get a thinner RNFL as false results. Another important thing, you have to look at the quality of the scan, whether there is any media opacity, dry eye, inability to fix, poor OCT lens centering, older devices, poor centration of the scan itself, and inexperienced operators. All these are going to give a poor quality scan. So next you have to look at the thickness map and the deviation map. So one important aspect of the thickness map, because this is the actual data of the patient themselves. There is no age match normative database happening in the thickness map. From the thickness map, you are going to get the deviation map. So this is the age match normative database comparison and how much deviation it is happening between the age match normative controls. So here you have the color coding. One good thing about OCT printouts is that you don't have to remember the color coding. The color coding will be displayed at the side of the maps itself. So 0 micron means thinner is blue and 350 thicker is red, especially in this part of the OCT maps. So let's look at the other printouts. So hourglass pattern is the normal RNFL thickness map pattern. So here you can see areas of thinning which is well demarcated. So these areas of blue are areas of thinning. When it comes to the deviation map, this is represented in red. Next is an advanced glaucoma where you are seeing overall lot of blues and very less amount of red color. So this is an advanced glaucoma. So once we have covered the thickness map and the deviation map, let us look at the RNFL thickness in the T-SNIT plot. So that we already discussed how the T-SNIT plot looks like. Apart from that, you have the quadrant wise and the clock hour wise analysis. So once again, there is a different color coding for this. Here, red indicates that it is abnormal, while green means that 95% of the normal population is falling into the category. And if it is somewhere in between, that is the yellow color indicates 5% of the normal population is falling in the category. So the color coding is also given here. You don't have to memorize the color coding. So next is the NRR thickness map. Once again, the color coding remains the same and it is again following the T-SNIT pattern. NRR, as I already told, it is going to be between the disc margin and the cup margin. Next is the key parameters table. Here the results are going to be compared with the normative database. So here once you have to remember is the disc area is always shown in gray. Why? Because there is no comparison that is going to happen with the age match normative database only for the disc area parameter. Rest of the color coding, green means normal and red means abnormal. So the normative database of size rest, here one point I would highlight is the disc area, if it is larger than 2.5 or smaller than 1.3, once again it is going to be shown as gray, and the age criteria also less than 18 years. So if you are going to get an OCT done for a patient less than 18 years, all these will be represented as gray or colorless. So here you can see that all are represented as gray without any color. So next is the extracted horizontal and vertical tomogram. So these are actually B scans that is happening. This once again is important for determining the quality. So what are you going to look here is whether the segmentation is properly done. Follow these red lines. They should fit the pattern of the OCT scan, and whether centration is happening properly. Next, let's go to the ganglion cell analysis. So what is ganglion cell analysis? Why it is needed? Because 50% of the retinal ganglion cells lies in the macular region. So in ganglion cell complex, it is RNFL plus GCL plus IPL. However, you have to remember this point: when it comes to size cirrus, it takes into consideration only the GCL and the IPA, and the terminology used is ganglion cell analysis. So ganglion cell complex includes RNFL plus GCL plus IPL. However, ganglion cell analysis in cirrus includes ganglion cell layer and the inner plexiform layer. So this is how the ganglion cell analysis printout looks like. So I'll show you some examples also. So you have once again the thickness map and the deviation map. So it is easy to interpret. Once you start interpreting, it will be almost similar, and the color coding will be given. Once again, there is a clock hour wise analysis and some parameters like average GCL plus IPL, minimum GCL plus IPL will be shown. So here you can see that the right eye is seemingly absolutely normal, while the left eye is showing some areas of thinning. So this is the panomap analysis. So this is nothing but you are going to integrate the macular ganglion cell analysis along with the optic nerve parameters. So RNFL, ONH, GCA, everything is shown in a single report. So let's jump into one example. So here you can see that the right eye, there is thinning in the thickness map, which is once again seen in the deviation map, and it is seen in the clock cover and quadrant white. Always look at the signal strength also before jumping into any conclusion. However, if you see one point here to be noted is the left eye is also showing some areas of RNFL loss. However, that is not seen in the OCT here. But look at the field, there is showing some area of some defect is being shown. While you look at the ganglion cell analysis, it is clearly depicted here. So always correlate structurally, clinically with OCT. Let's look at some artifacts and anatomic variation. These are going to be viva questions. So what exactly is the red disease? So OCT is showing red. However, the patient does not have the disease. Simply put, that is the red disease. OCT is showing green. Patient has the disease. That is the green disease. Let's look at some examples. So here, motion artifact is one of the common causes of the red disease. Here you can see the breakage of lines happening here. So that means there is a motion artifact. Patient has moved, which is once again reflected in your quadrant and clock cover. So next is floaters and vitreous opacity. Here is a clear floater. That area has not been scanned. That is shown in the deviation map, the clock cover quadrant. So the point here I am trying to make is that don't just look at the clock cover and the quadrant and jump into diagnosis, but see the printout as a whole. Next is the segmentation error. Here you can see that the horizontal, vertical tomogram, everywhere the segmentation is totally gone. So this OCT we cannot consider. Another anatomical variation is the shifted peak. So if you are having tilted disc or myopic patient, you can have these shifts. So this is not following the pattern of the T-SNET plot. There once again you can get the red disease. So this particular example I would like to show here, you are seeing one glance this OCT looks normal. But if you watch closely the thickness map, you are seeing a clearly demarcated area of thinning. Then you look at the fundus image, here you can see the RNFL defect. So this is a beautiful example of a green disease where OCT has failed to pick up. This happens when there is a very, very focal defect that sometimes the OCT can fail to pick up. Next, in macula GCL IPL, remember that you have to look for any macula pathologies that is going to affect the report. Last but not the least, the floor effect. So RNFL thickness does not go below 40 to 50 microns because of the presence of glial tissue and vessels. This is called the floor effect. So after this, especially in advanced glaucoma, there is no use of doing the optical coherence tomography. Just a brief, I'll just show the printouts of the guided progression analysis. For want of time, I won't be going into depth. So in GPA, what happens is there will be two baselines and it will be compared with the subsequent tests. So at least 5 tests is needed. So here you can see the 4 tests, like 5 tests. So baseline 1, baseline 2, you can switch the baselines also. There is something called the event analysis and the trend analysis. So simply put, event analysis is that at one point of time, so this examination is compared with the baseline. That is the event. If everything is put together in the form of a graph and you are seeing the trend over a period of time, that is the trend analysis. So these are the two printouts that you are going to get in a GPA printout. So these are the parameters. Once again, this is all color coded. So you'll be having easy to interpretation, like likely loss will be shown in red, possible loss will be shown in orange. So brief about the spectralis OCT. What is the difference? So here I already told you there will be a single calculation circle in cirrus. However, in spectralis, the advantage is you can have 3 calculation circles. This advantage is particularly useful when you are having high myope patients with a large disc, peripapillary atrophy, etc. So this is how a spectralis printout looks like. Once again, no need to confuse so much. So you will have a clear-cut explanation of everything in the printout. So this is an RNFL
Ma'am,
printout.
10 minutes are over, ma'am.
Yeah, I'll just wrap up in a minute.
Ji, ma'am.
So this quality is one thing I want to highlight. So there I said less than 6 is abnormal. Here you have to have values at least more than 20. Okay. So I'll skip this part and OCT report interpretation. I'll just give a brief summary and wrap up. So first you have to start by confirming the patient data. Then you look at the scan quality and whether the segmentation is good or not. Then you jump to the thickness and the deviation map. Then you go to the clock cover and the quadrant analysis. Then NRR thickness and parameters table. Last but not the least, it is very, very important to correlate clinically with fundus images, visual fields, IOP and gonioscopy. Thank you. Any further doubts, you can always write to me. Thank you once again for the opportunity.
Thank you, ma'am. This was exhaustive and a wonderful presentation. Pranav sir, any comments on the presentation,
No,
please?
it was very clear cut and very exhaustive and very clear. So nothing to add except there is always a confusion with the RNFL thickness map and the deviation map. The color coding is entirely different. In the thickness map, the color coding, the hot colors, they depict the thicker RNFL areas, while as in the division map, the red color that shows the defect, positive defect. So this has to be taken into account. The rest of the things are all color coded, and once the students start reading, they will find it very easy.
Thank you, sir. Thank you. So now we will go to our next talk by Dr. Parul ma'am. Dr. Parul ma'am is a senior ophthalmologist working as a professor in Government Medical College and Hospital, Chandigarh. So, ma'am, over to you. Visual field interpretation. I hope Dr. Deepika Sumant is able to share the screen next. Thank you, ma'am.
Well, good evening, everybody. 10 minutes is actually too less to do justice to visual field, so I'll be just sharing some clinical pearls which will not only help you during the exams but beyond the exams as a clinician. So one thing to remember is that although we are talking about standard automated perimetry, it's not an autonomous thing. The perimeter is automated, but the performance and the interpretation both are entirely human. So at all time points, we have to keep several factors, as has been highlighted by the previous speakers, in mind before we just label a field as a glaucomatous field or as a progressive field. So we have to remember that each time we have to correlate several things. So essentially to perimetry, there are three important elements. One is before the test, which requires a thorough preparation both from the clinician's perspective as well as the technician who is doing the test. During the test, you need to supervise the test, and after the test, the interpretation has to be done very carefully. So essentially, I'll be covering up 10 commandments across these three domains of perimetry that will help you to assess a patient properly. So before the test, you should train your technician personally. So they should understand what are the standardized instructions, how to position the lenses properly, and to recognize artifacts. Because if artifacts are coming repeatedly, it's no point wasting the patient's time and essentially inducing an element of fatigue. Second, both the clinician and staff should undergo a test themselves to understand that it is not as easy as it seems. So that improves your instruction ability and as well as interpretation ability of the test. So you cannot interpret what you have never experienced by yourself. You should explain the test purpose to the patient so they know what is expected from them, where they have to look, the importance of fixation. They have to expect lights appearing randomly. They have to press quickly once they see the light and blink normally during the test. And they should be told that there is a facility to pause the test if they are having watering of the eye. Also, the dark adaptation of the second eye should be done appropriately. A confused patient will always produce a confused field, which would be unreliable and non-contributory. So this is something which is very, very essential. Second, you should maintain a standardized testing condition. The light should be kept off when the machine is getting booted up. Boot up calibration, it actually depends upon the ambient light. So if the light is on when the machine is getting started, it will alter the contrast and your output will be different. So if you match a visual field which was calibrated in a light on condition versus a visual field which was done in a machine that was with the light off calibration, the outcome is going to be essentially very different. You remember that perimetry, it actually measures contrast and not just the brightness. Also, choose the right test strategy. you have to keep your patient's attention span in your mind. So an elderly lady of 78 years with some back issues is not going to sit through the entire test of CETA standard. For such a patient, choosing a CETA fast, which is relatively faster, but essentially gives you almost 80% accuracy, is a good enough choice. So keep patient's attention span, fatigue tolerance in mind so that you get the most information in the least amount of time. But remember that all the follow-up examinations should be of the same test type. You cannot match a CETA standard with a subsequent CETA fast. So stick to that one test strategy that you choose. So from a clinician's perspective, you can either use a 24-2 CETA standard or CETA fast for glaucoma. For certain set of patients where you think that there is a change and there is an early paracentral loss, you can choose a 24-2C CETA faster. For patients with advanced damage, a 10-2 or a macular test is the way to go because it gives you the information where it is really desired. And for neurological cases, a 30-2 test is good enough. So this is a image of a 24-2C, which is the latest edition. And here you see we have 10 additional points, which can provide you information about the paracentral area. Which eye to test first? Test a patient's better seeing eye first. Always remember to keep the foveal function on. So that will give you an idea about whether the patient is looking whether the patient is looking properly also, and if there is any foveal disorder. For a young patient, if the foveal value, threshold value, is somewhere in the 20s, there is definitely something wrong in the fovea and you need to look at it. Change the target size if the visual acuity is less than 20/200. So then you can step up to a Goldman size 5 from Goldman size 3. Always maintain proper patient positioning because that is going to give you a reliable result. The patient should be comfortable. The response button should be in the dominant hand and the hand of the patient should be supported. So always remember 3 L's: lumbar support, a good lid position, and lens placement. Superior limbus must be visible when the patient is performing the test. The upper lid definitely must not obstruct the field. These days, we see a lot of patients who are elderly and having dermatochalasis or lid issues secondary to prostaglandin-associated periorbitopathy, and all these lid issues, they ultimately result in a superior visual field loss. So that is something you can tape the lid of the patient and address. Refraction, the target distance of the test performance is 30 centimeters. If the patient has an astigmatism over 1.25 diopters, that should be corrected. In such cases, a spherical equivalent is a good choice. And in patients with more than 4 diopter of refractive error, a soft contact lens should be preferred. Especially in aphakics, always make sure that the patient is performing the test with a contact lens. Refractive scotomas are man-made defects, and that's something that we can look into. So this is one such aphakic patient with plus 13 diopter correction, and you can see there is an immense amount of damage that a rim defect we see. The moment you switch this patient to a contact lens, this entire rim effect disappears. So that is something that we must always tell our technician. Artifacts at times imitate disease. So if there is a lens holder rim artifact, that means if the lens is either not kept straight in its socket, or if there is a nose which is almost touching the lens, then that nose artifact can cause an inferior nasal step. So almost 10% of defects in perimetry are artifact induced. Always remember, with most modern machines we get, although a set of thin lenses, if you're not able to find a lens, please don't substitute it with a trial frame lens. All these thin rim lenses are the ones that we have to use for perimetry. During the test, the technician should monitor the gaze, the lid position, and the posture. A wandering eye yields a wandering field. So most machines have this small window wherein you can see whether the patient has a wandering eye or not. Pupil diameter, myotic as well as mydriatic pupils result in a wrong outcome. Meiosis reduces the sensitivity, while the overdilatation, it causes a peripheral blur and results in global indice artifact. A 2 millimeter constriction would result in about a 0.7 decibel sensitivity drop. So if the patient is on pilocarpine, that should be stopped like a week prior, and then a test should be carried out. So here we see it's a very small pupil resulting in an artifact. And here we have another very largely dilated pupil, 8 millimeters, and again we have a peripheral artifact. So always look at the pupil size. Don't leave the patient alone. Trained assistants must always be present. It's a supervised test, and therefore patients must not be left alone. Examine the fixation losses, the false positives, false negatives, and gaze tracking before you jump to a conclusion. No reliability would ultimately result in no diagnosis. So if there are a lot of false positives, you will get these white scotomas in the grayscale. And if you have a lot of false negatives, you will have a cloverleaf pattern. So look for these patterns. These actually resolve over a period of time as the learning curve gets over. Always interpret fixation. Look at the gaze tracker. We would want an even smooth line with minimal excursions. But if the gaze track shows upward deviation fully up, that means fixation is lost. And if there are a lot of downward deviations, it means that the patient was blinking during the test. Remember that perimetry compares patients to decade-based age norms. So crossing an age bracket may falsely sometimes suggest improvement. So somebody who was 59 years of age was showing a certain amount of damage, and the moment they turn 60 or 61, it may appear that there is a false improvement in the test. So always look at the end and beginning of age brackets very closely to see if there is any fallacious improvement. Learning effect, as you see, the patient has performed the test twice or thrice, and the so-called defect has disappeared as the patient has improved doing the test. So first test underestimates sensitivity, and the peripheral points in these first fields are most affected. Repeat testing always improves the reliability. Remember, false positives over 10 to 15% are unreliable. False positives over 33% actually imply a very trigger-happy patient. You need to tell them when to press and when not to press. So false negatives over 33% are flagged as double X, and they ultimately suggest fatigue and severe loss. And you also should check the amount of test time that the patient has taken. A long test duration results in fatigue. If you have a patient who is repeatedly having a left eye field which is coming unreliable, the next visit he comes, perform the left eye first, because by the time the left eye is tested, he's already fatigued. So in cases of left eye test unreliability, check the left eye first next visit. Prolonged test duration, as I mentioned, suggest fatigue. So try and switch to a test which is shorter in duration and gives you the most information. Grayscale is a very gray area because although we are just checking 54 to 76 points, the grayscale is filling up those gaps with 2000 symbolic interpolations. So basically just use this to explain to the patient that, see, this part is non-functional, and if you don't treat your disease seriously, it is going to become more involved and you are going to have disability in moving around. So treat it as an illustration to explain to your patient and not as an evidence for yourself. Mean deviation, as you all know, is actually nothing but diffuse loss. You must remember that 3 decibels would result in a smaller relative afferent pupillary defect. And if the difference between mean deviation between the two eyes gets more prominent, we will have a more prominent RAPD. So RAPD must always be checked, and that should be correlated with the mean deviation. If the visual field defects appear to worsen, always check for changing visual acuity and worsening of cataracts and any other media opacities. Pattern standard deviation, as the disease advances, it tends to improve due to global depression. So if the pattern standard deviation is improving, you will get a printout like this, wherein it is mentioned that the field is severely depressed. VFI's 100% is normal, 0%, as we all know, is perimetrically blind. It's actually tracking the velocity of the disease. Remember, when you are trying to choose VFI values for predicting a trend-based progression analysis, you choose a reliable visual fields. So unreliable visual fields will cause a fallacious interpretation. Remember, progression is not binary. It is not present or absent. You have to remember that there will be always progression. The rate of change should be acceptable to us. The slope should not be very steep. So this is how multiple VFIs are plotted, and it gives you a prediction of how the disease is going to be over the next 5 years. So as I've already mentioned, as the disease progresses, PSD actually dips much more profoundly. And at one point, it tends to improve. But as the disease advances, all the parameters, they touch rock bottom. And at this point, performing a macular test or a 10-2 test makes more sense rather than doing a 24-2. Look at the out of both the eyes together, look for symmetry. Remember that structure and function do not correlate in the beginning. Sometimes OCT may change before the fields or vice versa. Whenever you are interpreting, always look for progression analysis in both the OCT as well as the perimetry and figure out whether the rate of change is acceptable, whether it is just age-related decline or is the disease progressing. Always evaluate for a compatible disease, because a patient with glaucoma can have multiple disorders. They can have laser marks because of the diabetic retinopathy that was treated with a PRP, or they can have papilledema, or they can have any other retinal or a macular disorder, which can also contribute to the visual field effect. So that's something that we have to look for. Remember, the machine detects light, the field detects pattern, and it is for us to detect the truth. So reliability is the most pivotal thing. The pattern is the next, and the diagnosis is last. And remember that there are multiple diseases that can coexist in a patient's eye and not just glaucoma. Thank you.
Thank you, ma'am, for this exhaustive presentation. It was a wonderful presentation. I think all the points were covered. Ranjan sir, would you like to comment on the presentation, please?
No, for perimetry, 10 minutes too short a time to cover up. So just like to add that the perimetry is basically divided into two parts. One is a static perimeter and the other one is a kinetic. What we are dealing with is a computerized perimetry, which is a static perimeter, and which essentially has two components. One is a point pattern, the other one is a strategy. The point pattern is the pattern in which the computer throws the light and the patient picks up. Like 30-2 has got 76, 24-2 has got 54 likewise. And the second is the strategy. The older strategy used to be a full threshold strategy, which used to consume a lot of time. The newer strategy is like the fast pack, the Sita standard, which takes less time and is almost as reliable as the older strategy. So one should probably, one nowadays only sticks to the newer strategy. So these are the few things. And one thing, the stat pack analysis. This is a computerized software which has the normative data, which compares the patient's data. And accordingly, what is the difference between the normative data of that particular age patient and this patient, that is given in the printout. So these are few important aspects that have to be kept into consideration.
Thank you, sir. Now we'll go over to the next talk by Dr. Deepika Sumant. Are you ready to present your slides, Doctor? The topic is optic disc evaluation. Yeah.
Yes, am I audible?
Yes, you're audible.
Is my screen visible?
Yes, it is visible.
Okay. So good evening, everyone. Today I'm going to talk about one of the important topics in glaucoma evaluation, which is the optic disc evaluation. Clinically, how do you examine the optic disc and say whether it is glaucoma or not? It is especially important in cases of normal tension glaucoma, where the IOP is still normal, and only the disc can give you a clue whether it is glaucomatous or not, so that you can advise further evaluation and confirm the diagnosis. So this is how a normal optic disc looks. It is a vertically oval structure, which is vertically a little longer than horizontal. The vertical size is 1.92 mm approximately. Horizontally, it's 1.76, and the surface area is 2.69 millimeter square approximately. The optic disc margin is seen as a white circular band at the edge of the disc. It is called the scleral ring. The optic cup is the central depression in the optic disc, which is devoid of neural and glial tissue, thereby exposing the lamina cribrosa. A healthy neuroretinal rim is a pinkish orange in color. It is it lies between the optic cup and the optic disc margin. So it typically follows the Essent rule, where the inferior rim is the thickest, followed by the superior, nasal, and the temporal. So how do we examine the optic disc? What are the ways of examining? We can see the optic disc with the help of a direct ophthalmoscope, which gives a wide magnified view, but it is monocular and lacks stereopsis. Slit lamp indirect ophthalmoscopy with a 90D lens or a 78D lens gives a good stereopsis, a fairly good magnification with good disc details can be assessed. You can also use a disc photography or a red-free fundus photography to look at the disc features. Quantitatively, if you want to assess the disc parameters like disc size, cup size, asymmetry percentage, and the level of thinning, we need a disc photography with digitalization, stereo disc photography with optic disc analysis, OCT, HRT, or a GDX machine. So for the exam point of view, if in the exams, if you are asked to tell about, describe about features of the disc, you should always start from the size shape. You should never jump directly to the cup disc ratio. So start from the size of the disc, whether it is a normal size, average size, small disc or a large disc. Shape of the disc should be explained like horizontally oval, vertically oval, whether it is tilted disc, and explain about the neuroretinal rim, the color of the neuroretinal rim, whether it is pale or pink in color, whether there's any localized notching or thinning. Then comes the cup disc ratio. You can describe the shallow or the deep cup and explain the cup disc ratio. Cup disc ratio is normally 0.3 to 0.4. Then you can explain about the asymmetry of the disc compared with the other eye. And then comes the vessel position and the vessel changes, which I'll be talking about later. RNFL defect changes can be viewed in detail with the red-free filter. Always look for optic nerve head hemorrhages at the disc margins, which are very important. And also look around the disc, peripapillary atrophy, alpha and beta zone. So this is the disc size and the cup size and the neuroretinal rim. Coming to the disc size, so this is the normal scleral ring at the limits of the optic disc. This can be measured with the help of, clinically, it can be measured with the help of a slit lamp. When you're seeing a 90 with a 90D or a 78D, you can reduce the slit size to look at the size of the disc. With the help of a correction factor, you can arrive at the approximate disc size. Optic disc shape, as I already told, it is vertically oval. And optic cup is the central portion of the optic disc. It is the cup disc ratio we call is the ratio of the disc cup diameter to the disc diameter. Normally it is 0.1 to 0.4, but it is always to be correlated with the size of the disc. Smaller discs have a smaller cups and larger discs have larger cups. In glaucoma, especially vertical cup disc ratio increases because the superior and inferior poles are the first to be affected in glaucoma. So neuroretinal rim is the intrapapillary extension of the nerve fiber layer. It is the width between the outer edge of the disc and the inner edge of the rim. So normally, as we all know, it is the Isent rule. This Isent rule is broken in glaucoma. We can also see signs of focal notching, focal thinning, as we can see in this picture, inferior notching, the corresponding nerve fiber layer defect. Next, we look at the neuroretinal rim color. This is the normal neuroretinal rim color, which is a pinkish to reddish in color. Sometimes with a large disc, but the pallor is not there, still pinkish and normal. The last image shows a more pale disc. Pallor is more than cupping. If you see such a disc, you should always suspect non-glaucomatous causes of optic neuropathy. Continuous deepening of the disc causes exposure of the underlying lamina cribrosa, where you can see gray dots, which are referred to as laminar dot sign, which is seen in glaucoma. But it is not pathognomic of glaucoma. Sometimes it can be seen in normal individuals as well. Coming to cup disc ratio asymmetry, here the size of the disc is almost similar between both eyes, but the left cup is little smaller than the right eye. But still, it is still a healthy neuroretinal rim, 0.6, 0.4. Any asymmetry of more than 0.2 should increase the suspicion of glaucoma. Coming to disc size asymmetry, when the disc size itself is different, cup also will look different. Right eye shows a smaller disc with a smaller cup, left eye larger disc with a larger cup, still a healthy neuroretinal rim in both eyes. RNFL changes are also very important in diagnosis very early glaucomas. As we can see in the picture, there is an inferior wedge RNFLD with a localized notch corresponding field changes, early field changes. Vascular changes are very important in cases where you are not able to see the neuroretinal rim margin very clearly, sloping or not clear margins. You should look at the vascular changes to look for diagnosing glaucoma. There can be disc hemorrhages, bioneting sign, nasalization, barring of circumlinear vessels, etc. So disc hemorrhage is a splinter-like flame-shaped hemorrhage at the border of the optic nerve head, usually in the infratemporal or supertemporal. It is usually associated with normal tension glaucoma. It is important because whenever there is a disc hemorrhage, the progression can occur rapidly. So you need to have a close watch in such patients. Bioneting sign is a sharp bend which the vessel takes at the disc margin in cases of glaucoma. As you can see in the inferior rim, there is a sharp bend where the vessel comes out. Nasalization of vessels can be seen. Again, not pathognomic of glaucoma. Bearing of circumlinear vessels, when the rim margin recedes, you can see the vessels unsupported or hanging in midair. That is called bearing of circumlinear vessels. That is also a sign of glaucoma. Peripapillary atrophy can be seen in and around the optic disc. There we have zone alpha and zone beta. Zone beta is very important in glaucoma. It's a visible sclera and choroidal vessels, atrophy of P and the choriocapillaries. But again, it is associated with severe glaucomatous optic atrophy. It can be present even in normal eyes. Some of the examples I would like to discuss. This is a normal disc with a robust RNFL. Follows the Isent rule, no peripapillary atrophy, no disc hemorrhage. It's a normal disc. Here again, we see a large cup, but again, it follows the Isent rule and the neuroretinal rim is pink and healthy, so it's a normal. Here we see a disc hemorrhage in the inferior infratemporal quadrant with a focal notching and corresponding nerve fiber layer defect. Here we can see a lot of peripapillary changes with the corresponding inferior notching. This is again a large disc with a large cup and the fields are normal, neuroretinal rim is perfectly healthy. This is an average to large size disc with an inferior thinning. We can also see a corresponding neuroretinal nerve fiber layer defect. This on the outside looks like a 0.4 to 0.5 cup, but there's a subtle inferior notching with a corresponding nerve fiber layer defect. This is like a myopic fundus with a tessellated fundus where the nerve fiber layer defects are not appreciated very clearly. Almost total cupping, you can see almost 0.8, 0.9 cupping where the rims are totally gone. This is a picture of the disc hemorrhage, inferior disc hemorrhage with the corresponding nerve fiber layer defect and a notching. Again, a subtle notching inferiorly where you should look at the nerve bending, vessel bending and the wedge NFLD is there. This is a patient who we have followed up over a long time. We can see the superior nerve fiber layer is going from a wedge shape to the diffuse with the corresponding field changes. We can also see in the second picture a disc hemorrhage in the inferior margin, which is progressing to a nerve fiber layer defect, which is yet to show in the field. So all these discs are normal, small, mid-size, large, but they're all normal still. Thank you.
Nice presentation. Do we have any comments from our Pranav, sir?
It was a very nice presentation. I mean, disc evaluation and disc examination basically is one of the most important examination in diagnosing glaucoma. And every patient should undergo either a direct or an indirect ophthalmoscopy to find out the situation of the disc, the kind of disc the patient has. That gives a clue to the fact that whether the patient has got a glaucoma or not. Just two couple of points to highlight. One is that the large disc will have a large curve. That doesn't mean it is pathological. And the smaller discs will have small curve. So this has to be kept into consideration. The second consideration is that in glaucoma, the pallor, the cupping is more than the pallor, whereas in neurological conditions, the pallor is more than the cup. So these are the things which has to be considered, right?
Thank you, sir, for your valuable comments. Next, can we call upon the next speaker, Dr. Arnav, to present? Can you share your screen?
Yeah, just a minute, sir.
To go to middle, share screen button is at the bottom.
Yeah, just a minute. It's actually asking for. Sir, just give me a minute.
Okay.
I'd have to leave the meeting and rejoin.
Okay, maybe. Dr. Divya, are you ready? Dr. Divya? Can you present?
Yes.
Yeah.
So
yeah, Dr. Arnav will present next. Yeah. Yeah, you can start your screen sharing. Slideshow.
Yeah. Yes. So before starting, am I audible?
Yeah, you are audible.
Okay, thank you. So before starting with the discussion, I just like to say that a good clinical history and a good clinical examination does 75% of the job, and the remaining 25% is by all the investigations. Okay, because it will help us to correlate our clinical findings. So I'll just quickly go through the case discussion. And at the end of the discussion, I'll be describing about the management. So we have the first case. It's about a 40-year-old female who came for a routine examination with no significant history. Best corrected visual acuity was 6.6 and 6 in both the eyes, and intraocular pressures were raised to 28 and 30 millimeters of mercury in right eye and left eye respectively. The anterior segment examination was within normal limits, and gonioscopy showed open angles. So this is the fundus picture of this patient, which looked like CD ratios was around 0.4:1 with healthy NRR and good RNFL visibility. We also did an OCT and visual field analysis, which turned out to be normal. But now, considering this young lady who just came for a routine examination accidentally had her pressures elevated, gonioscopy showed open angles, and the rest of the examination was within normal limits. So now, will you treat this patient? So what is the other investigation that you have to look into? So first of all, you should know about the central corneal thickness in this patient. So this turned out to be 418, 478, which is slightly on the thinner side. So now, will you treat this patient? Yes. What is the diagnosis? It's a case of ocular hypertension. So you know ocular hypertension is a condition which affects at least 4 to 7% of the population over 40 years of age, which is characterized by only raised intraocular pressure without any glaucomatous damage. So for this, you have to know about the OHTS study, which describes about the risk factors which involved, so that causes the conversion into primary open-angle glaucoma. So these include raised baseline intraocular pressure, elderly age groups, thinner CCTs, large CD ratio, and large greater the pattern standard deviation. So factors which were examined in the OHTS study but found to be insignificant were myopia, diabetes, and family history of glaucoma. So at the end of the study, they concluded that the group which was kept under observation, they had a higher risk of converting into primary open-angle glaucoma than the group which was treated with anti-glaucoma medications. So now coming to our case 2. So we have this 68-year-old female who had blurred vision in both the eyes with nil significant history, had a best corrected visual acuity of 6.6 and 6, and intraocular pressures were 26 and 27 millimeters of mercury in right eye and left eye, respectively. On anterior segment examination, she was found to have cataractous lens, and gonioscopy shows open angles. This is the fundus picture, where we can appreciate that there is advanced cupping in both the eyes. In the right eye, you can see there is 0.9:1 cupping with bipolar notching almost. And in the left eye, there's almost near total cupping with rim loss more than 180 degrees. So one has to correlate your findings, the clinical findings, with that of the OCT, which clearly shows there's a bipolar RNFL loss involving the GCC. And when you do a visual field analysis, you can see there's a superior and the inferior arcuate defects seen in both the eyes, in the right eye as well as in the left eye. So now, this is a straightforward case of primary open-angle glaucoma, where the patient had raised intraocular pressure, open angles on gonioscopy, advanced glaucomatous damage, with corresponding changes in the OCT as well as the visual field analysis. So primary open-angle glaucoma, you should remember that IOP is a key modifiable risk factor, and always rule out the signs of secondary glaucoma first before terming it as primary open-angle glaucoma. So they can ask you in the exams about the pathophysiology of POAG. It's basically a trabecular meshwork dysfunction. So that causes an increased resistance to aqueous outflow, causing a raised intraocular pressure inside the eye. So this raised IOP can cause mechanical as well as vascular changes on the optic nerve head, resulting in ganglion cell apoptosis. Sometimes in the viva, they can also ask you what are the genes involved. So it can be a myocilin gene or optineurin gene, which are broadly accepted as causing glaucoma. Now coming to our case 3. So we have this 45-year-old gentleman who came for a regular examination. This time he had a family history of glaucoma and a mother, and best corrected visual acuity showed 6.6 and 6, but the pressures were within normal limits. It were in mid-teens. The anterior segment showed within normal limits and gonioscopy open angles. So if you look at the fundus, you can clearly appreciate that pretty normal fundus, which shows 0.6:1 cupping and almost healthy NRR. But when we did a visual field analysis, we can see certain changes in both the fields, like superior changes in the superior quadrant as well as in the inferior quadrant in the right eye. So even on OCT, you can clearly appreciate there's a borderline change in both the infratemporal region in both the eyes. So on dilated examination, we can see here there's an inferior rim thinning. So that means the ISNT rule is not maintained. Second, we can see there's a RNFL defect which has been seen in the inferior region. So now when you correlate your findings with that of the visual field analysis, we can see there's a corresponding defects on the visual fields, showing a superior defects in the left eye as well as superior and the inferior defects in the right eye. So now considering this young gentleman who just came for a routine examination with a family history of glaucoma and pressures within the normal range, but still he had changes in the fundus as well as in the OCT and visual field analysis. So the diagnosis at this point will be normal tension glaucoma. So it is characteristically bilateral, but often it is asymmetric. So sometimes they can ask you what are the vascular risk factors causing normal tension glaucoma. It can be a nocturnal hypotension, a vasospasms like migraine and Raynaud's phenomenon, obstructive sleep apnea, ischemic vascular diseases, autoimmune diseases, and coagulopathies. The examiner might ask what is the characteristic hemorrhage and which is the characteristic site for a normal tension glaucoma. It is usually the infratemporal region, and it is also called as Grant's hemorrhages or Vancouver hemorrhages. And what is the significance of the disc hemorrhage? So it is a marker of active progression. It indicates an ongoing retinal nerve fiber layer loss, and it's a strong predictor of visual field worsening. So the characteristic visual field defects in NTG tend to be more focal, deeper, and they are closer to the fixation. So coming to the management strategies, as already discussed, the OHT is based on the high risk factors. And primary open angle glaucoma, obviously you have to start the patient on anti-glaucoma medications, lower the intraocular pressure and monitor the progression. And for an NTG, you have to address the vascular factors as well. So always set a target intraocular pressure. So in the exam, they can ask you, what do you mean by target IOP? The pressure at which the RNFL, damage is retarded. Okay, so how would you classify the disease as mild, moderate, and severe? So based on the various criteria like AO criteria or Hodap-Parrish-Anderson classification based on VFA. So you can classify as mild, moderate, and severe, and based on that, you have to set a target range. So obviously, the first line of preference will be the anti-glaucoma medications, and that too, the prostaglandin analogs are the first drug of choice, followed by beta blockers, alpha agonists, carbonic anhydrase emitters, and rho kinase inhibitors. So if the pressures are still raised, then you can think about laser trabeculoplasty, so where SLT is preferred over ALT because it causes minimal structural damage as it targets only the pigmented trabecular meshwork cells and can be repeated also. So there's a 20 to 30% reduction in the intraocular pressure. So in case if the pressures are not getting controlled, even on maximum medical therapy and laser therapy, then you have to go for surgery. Or if the patient cannot adhere to the necessary medical regimen, or in case if there is any progression seen on visual field analysis, so in that case, you have to think about going for surgery. So these are some of the studies that a postgraduate should know about, like the OSTS, the EMGT, CNTGS, AGES, and the SIGETs. So take-home message, primary open glaucoma is a silent but progressive disease where intraocular pressure is the only modifiable risk factor. Always, you have to dilate the patients and do a thorough optic disc evaluation. And once the patient has been diagnosed, set a target intraocular pressure. Always keep monitoring the condition or the progression of the condition. And just remember that technology will just help to support your clinical findings. Thank you.
Thank you, Dr. Divya, for a wonderful presentation. For want of time, we'll move on to the next person. Okay, if Sir has any comments?
No, just one comment, quick comment on the first case, in which the pressure was 28 and 20 and 30. The central corneal thickness was somewhere around 480, 490, if I remember correctly. Right.
480.
Yeah. So there is a conversion formula for calculating the actual intraocular pressure with that corneal thickness. And it lies between 15 to 25 microns for 1 millimeter of mercury. So that can be correlated. So in that way, if the average corneal thickness, you consider the Indian corneal thickness is around 530 to 540. So that way, the pressure that you measured in 490, 480, that would have gone up to +3, +4, something like that. So that also has to be considered. Right.
Thank you, sir, for your valuable suggestions. And Dr. Divya, can you stop unshare your screen? Stop sharing your screen. Yeah, Dr. Arnav, I think you.
Yeah.
Yeah.
Is my screen visible?
Screens are visible and you are audible. You can go on. Yeah.
Good afternoon. I'm Dr. Arnav, and thank you for this opportunity. I'll be speaking on congenital glaucoma. So congenital glaucoma is an entity which fails every sort of classification or treating strategy we use for adult glaucoma. So the current definition for classifying and defining congenital glaucoma is given by Childhood Glaucoma Research Network, where there are 5 parameters which are considered. It's IOP more than 21, optic nerve head cupping, which is suggestive of glaucoma, the presence of corneal changes like increased corneal diameters, corneal edema, or limbal stretching or hair striae, a myopic shift or progressive change in refractive error, and a visual field defect, which obviously it's very difficult to perform in a child. So if 2 or more of these features are present, we define it as a childhood glaucoma. And if there's just one of these features, it's a glaucoma suspect. Now, what are the main classes of childhood glaucoma which we deal with? It's primary congenital glaucoma, which is usually associated with ophthalmos if there's no other cause for glaucoma in this age, and the corneal diameters and axial length are more or less normal. It's termed as juvenile open angle glaucoma. Now, there can be secondary glaucoma. Secondary glaucoma can be associated with inherent ocular or systemic diseases. And few of the glaucomas, they are truly secondary, where they are either because of trauma or uveitis or following a cataract surgery. So this talk would mainly focus on primary congenital glaucoma. The prevalence of primary congenital glaucoma is about 1:10,000 in Western population, whereas the prevalence is much higher in India. The mode of inheritance is mainly autosomal recessive, with CYP1B1 being responsible for about 45% of the cases. There are a few truly autosomal dominant forms which are known, and these are caused by FOXY1 or TEK mutation. The classic triad of congenital glaucoma is ophthalmos, which is increased corneal diameter because of raised IOP, epiphora, and blepharospasm because of increased heightened sensitivity because of associated corneal edema. Now, the cornea may be completely clear with just increasing diameters, or it may be hazy, either in the center or involving the whole of the cornea. Glaucoma may be either unilateral, which is seen in about 10 to 15% of cases, and it is bilateral in the rest. So what is the problem which leads to increased elevation? So primary congenital glaucoma is a developmental problem. Normally, neural crest cells in the region of the iridocorneal angle, they start to apoptosize, and the anterior uveal tissue, it slides back to reveal the normal angle. Now, if there is any problem in the apoptosis of the primordial neural crest cells which lie in this region, or any problem in the recession of the iris and the anterior uveal tissue, the filtration from this area would be impaired, because the normal porosity of the trabecular meshwork and the access to the lens canal is not developed yet. So this is the reason why the IOP increases. And when the IOP increases at such a young age, when the globe is still elastic, it leads to the various manifestations of childhood glaucoma, So here we can see the typical gonioscopic features, which is a high iris insertion. There can also be a very featureless angle. This is because of improper apoptosis of the primordial cells, and a combination of both can also be seen. So, histopath usually shows poorly differentiated trabecular cells, and the classic Barkan membrane, which is the primary site of resistance at the angle of these eyes, can also be demonstrated on ASOCT. Here's a UBM picture showing a high iris insertion with no developed trabecular meshwork in the primary congenital glaucoma eye, whereas the insertion is normal, and a faint highlight of trabecular meshwork in the Schlemm's canal can be seen here in normal eye. Now, this is something which I want all of you guys to take a screenshot of. We'll be discussing all the 4 parameters which lead to a diagnosis of glaucoma. Now, when the child is born, the IOP is not 10 to 21. That's the normal IOP range for an adult. When the child is born, the IOP is about 8, and it keeps on increasing to reach adult value at about 9 to 10 years of age. So even an IOP of 14 to 16 with features with support congenital glaucoma is typically diagnostic of this disease. We do not target a IOP of 18, 20, 22 in these eyes, but rather the target should be very low, because that's what the normal IOP for this child is. Measuring the IOP is also difficult. So the child has to undergo repeated examination of under anesthesia. The IOP is also dependent on the type of anesthetic used. You can take a screenshot of this if you want. We use chloral hydrate, which is oral and has nil effect on IOP. If the child is actually taken under anesthesia, the non-depolarizing agents, they have a tendency to mildly reduce the IOP. Depolarizing agent like succinylcholine increases the IOP, and endotracheal intubation induces endotracheal spasm, and hence it also increases the IOP. So if you are sedating the child, take the IOP as the very first investigation. But if you're intubating the child, take the IOP as the very last measure, because intubation can increase IOP. Now, the definition of corneal diameters: any corneal diameter which is more than 11 at birth is pathogenic. 12 millimeter under 1 year of age is pathogenic. And if the corneal diameter is 13 or more, it's pathogenic. So this is the definition of ophthalmos as per age. The axial length also tends to increase. The initial increase in axial length is quite a lot, and the axial length increases on to the adult level by 3 to 5 years of age, after which there's very insignificant further increase. Now, all eyes with increased corneal diameters or increased cupping is not glaucoma. Let's take an example of this case. So the corneal diameters were very borderline, and the disc here was very, very atypical. So you can see it's a large disc with a large cup. Myopic changes are there, but there's a very stark pallor which you can see here. The temporal rim is completely pale. We went on to do an MRI in this child, and what we found was periventricular leukomalacia, which manifested as optic nerve head cupping. Now, these neurological causes of optic neuropathy can also develop non-glaucomatous cupping, which is what we saw in this child. And suppose if we have diagnosed the child as having glaucoma, like in this case here, we can see a slightly hazy cornea with ectropion UVA. This is the phenotype which is typically seen in primary congenital glaucoma. But is it actually PCG? No. Here we can see 360-degree posterior embryotoxon, which is very typical of ARS. Now, diagnosing this child as ARS changes the management completely. In PCG, where angle surgeries usually tend to work, in axon field, the role of angle surgery is pretty poor. So this eye was eventually planned for a combined trabeculectomy. And diagnosing the child right also has ramifications in genetic counseling of the parents. Childhood glaucoma is primarily a surgical disease, and medical management is given only to delay the surgical procedure. Three medications are quite safe in infancy and neonatal period. These are britoxolol, pilocarpine, and prostaglandin. Timolol should be avoided in neonates because it can cause bronchospasm, alpha agonists in children below 6 years of age because of CNS depression, and ROCK inhibitors, well, they cause these, which might be very, very troubling for the child and the parent. The IOP reduction is poor and the prevalence of side effects is way too high. The first chance at surgery is the best chance in a child, and hence we need to choose the most appropriate surgery. So what are our surgical options? We can either treat the angle, which are angle surgeries. So this is the goniotomy where we incise the angle and just reduce the resistance. It is said that incising the angles recruits more and more collector channels, and the angle may start to behave completely normal like it used to before. So goniotomy typically involves treating 120 degree to 150 degree of the angle. What if we can treat whole of the angle? So this is what we do in gonioscopy assisted transluminal trabeculectomy, where we are able to treat 360 degree of the angle. So here we can see high iris processes and poor differentiation of the angle. I've made a goniotomy cleft. This is the 6-0 proline whose tip has been cauterized, and we are threading it into the Schlemm's canal. It passes around the eye and comes out from the other side. So we can see the tip now emerging from the other side of the cleft. Now we'll be just pulling the suture, and this deroofs whole of the Schlemm's canal. These are, so this is another way of angle surgery. Here we are using an illuminated microcatheter, and we are performing an external trabeculectomy. Here you can see the catheter going through around the arc. So performing this with a suture is quite difficult because it's more or less a blind procedure. So hence we mainly use an illuminated microcatheter whose availability is quite scarce in resource limited settings like India. Here you can see the tip of the light bulb coming out from the other side. It emerges from the other side, and you can just pull it to deroof the Schlemm's canal. So these are a few techniques we have described to improve ab interno angle visualization. So how do we decide whether to do a partial angle treatment or a complete angle treatment? So it's a dictum in childhood glaucoma, especially primary congenital glaucoma. Treatment of the angle leads to recruitment of collector channels. These collector channels do function throughout the life, and the IOP reduction might be even more significant than what you have with the trabeculectomy. So always prefer complete treatment of angle because it can actually eliminate the disease in the eye. So what if the accessibility to the angle is poor? This is where we do the gold standard surgery, a combined trabeculectomy. How do we decide? So eyes with less severe congenital glaucomas and mainly PCGs go for angle-based surgery. Eyes with secondary glaucomas and more severe PCG go with a CTT. When no delay, as soon as possible when the child is stable enough for anesthesia. So there are a few prognostic indicators which also help us decide which surgery to go for. If the onset of glaucoma is infantile, we go for angle surgery, which has very good prognosis. In neonatal and late onset cases, the prognosis of angle surgeries is pretty dim. Hence, we prefer a combined trab and trab. Corneal diameters less than 14 respond well to angle surgery. If it's more than 14, go for a CTT. Axial length, again, here, axial length more than 26 is usually a very severe form of PCG. It has a very high risk of retinal detachment, and the surgical prognosis is usually poor. And if concomitant ocular or systemic anomalies are present, go for a CTT. Never attempt an angle surgery because angle surgeries respond very poorly in these eyes. These eyes do have improperly developed Schlemm's canal. So even if you treat the angle, treat the trabecular meshwork, the accus can't go beyond. So there's no point of doing it. If you treat it right at the right point, you can see that the cornea clears up and the child's functional rehabilitation begins from the moment you take the child under the blade. The cupping is also reversible, especially when performed at a very early stage. However, these hair striae, they do not go away, and these might be a very big reason why eyes with unilateral glaucoma remain amblyopic.
Dr.
So
Arnav,
these,
can you
yes,
sum it up? Yeah.
it's about to be over.
Yeah.
So we perform an examination under anesthesia every month for the first 6 months, and then onwards every 3 monthly till the child is old enough to cooperate in OPD. Thank you.
A wonderful presentation, Dr. Arnav. Due to want of time, we ask you to wrap it up soon. Yeah, can we have Dr. Reena?
Yeah,
Ma'am?
hi, good evening.
Yeah, thank you, ma'am.
Okay, let me just start. I'll just start my screen share. 1 second. Is my screen visible?
Not yet, ma'am.
Okay.
I think you have not, but press the share button, which is at the bottom center.
I did that. Let me just do it 1 second. I think he was already sharing his, so mine wasn't going through. Yeah. Now can you see it?
Not. Yes, ma'am. It started. You can start your screen sharing.
Yeah. So I'll be talking about primary angle closure disease spectrum, and I've made the presentation mainly with the aim and objective of the students to benefit for the examination. And I think the key important things to remember is that the angle closure glaucoma, primary angle closure glaucoma, is seen in more than 50% of our glaucomas that we see in our OPD. And it remains a major cause of bilateral blindness, and it's more aggressive than the open angle disease. And that's another reason why very often in your OSCEs or in theory, primary angle closure glaucoma case can be, or a question can be present. So you must remember to know your ISGEO classification well, and don't get confused with the stages. Very often when we ask the young ophthalmologist or postgraduates about the staging and understand the difference between primary angle closure suspects and primary angle closure or primary angle closure glaucoma eyes, sometimes there's a confusion. So you have to remember that the suspects are nothing but patients where the anterior chamber is shallow and you have iridotrabecular contact on gonioscopy. And when I say gonioscopy done the right way in a dark environment with the light of the slit lamp not impinging onto the pupil, with an indentation. Gonioscopy where you're not pressing onto the cornea, you're not indenting yet, without indentation, where you see that there is an appositional closure where your iris is covering the trabecular meshwork in more than 2 quadrants. We define it as primary angle closure suspect eyes. But it's important to remember in PACS stage, you have no increase in intraocular pressure and you have no peripheral anterior synechiae or goniosynechiae in the gonioscopy. And of course, the optic nerve is healthy. So that is what PACS eye is. Now, what is primary angle closure eye? An eye which has shallow AC and more than 180 degree or equal to 180 degree ITC, along with either raised intraocular pressure above 21 or even a single goniosynechiae in the angle that you can see on gonioscopy. Once you see a synechiae formation and you see the pressures are high, but the optic nerve head is still healthy, you will call these patients as primary angle closure. The moment in a primary angle closure eye, you have the changes in the optic nerve, which are suspected of glaucoma and having correlated field defects, then the diagnosis becomes primary angle closure glaucoma. Because as we know that glaucoma is defined as optic neuropathy. So once the optic neuropathy sets in, we define it as primary angle closure glaucoma. Now this is very important to remember because the treatment modalities or when to do a PI or not, which we'll discuss, depends on at what stage or what is it that you're dealing with in the disease spectrum. Just a suspect or a primary angle closure or a primary angle closure glaucoma eye. And the other thing you have to remember that an acute angle closure attack is defined as acute primary angle closure. They usually don't call it acute angle closure glaucoma because sometimes despite developing an acute angle closure with very high pressure, if you control it in time, you can still sail through without causing an optic neuropathy in some eyes. Hence, it is classified as APAC, which is acute primary angle closure. Now, this is just the table form of the same thing for you to, and this is pretty nice to put it in the exam for the examiner to know that you know this very well. So as you said in PACS, you only have the ITC and no synicate, normal pressure, normal nerve. Whereas in the PAC, you'll have the ITC with maybe or maybe not a goniosynicate, but the IOP will be raised. And the optic nerve is normal. PACG, you will have ITC, you will have some goniosynicate, you will have raised pressure and an optic neuropathy as well. Important thing to know other also is what are the mechanisms of primary angle closure. Of course, pupillary block remains the most important pathophysiological factor in angle closure eyes, where we know that there is resistance at the pupil, which increases the pressure gradient in the posterior chamber to be higher as compared to the anterior chamber pressure, leading to the bowing of the iris anteriorly, which we call as iris bombay, and hence tightening up the angle and closing it and causing angle closure disease. But it's important to understand that with the availability of UBMs and ASOCTs, we've learned over the time that there are lots of eyes which have non-pupillary mechanisms at play. And that's the reason why, despite a PI, we can continue to see progression in some eyes, or we still don't see any benefit in IOP lowering after a PI in some eyes, not just because it's synically closed, but also because there are other pupillary, non-pupillary block mechanisms at play. So the important non-pupillary mechanisms to understand is number one, plateau iris, where what you have is an anteriorly placed ciliary process, which gives you, when you do a gonioscopy, a double hump sign, where you have the sine wave sign, where the peripheral iris is raised, then you have a little dip, and then you have another rise in the tissue of the iris. And also when you do an LPI, a laser peripheral iridotomy in such eyes, the angle appositional closure persists because it's not the pupillary block that was at play. The other thing that is very often the cause of angle closure disease, which is not pupillary block mechanism, is the lens itself. Because now we have enough evidence that a thick lens, especially in Asian eyes and a small hypermetropic eye, can be the cause of primary angle closure. And also some of these lenses might not be so thick, but they might be anteriorly positioned. And that's the reason why measurement of lens vault, like you can see in this anterior segment ASOCT image, that the lens vault, which is measured if you draw a line between scleral spur to scleral spur, and you measure the entire lens above that, that's your lens vault. And if the lens vault is high, you also know that that is another mechanism that is at play, which is the cause of the angle closure in this eye. Of course, there are also peripheral iris crowding that can cause pupillary block. Either the peripheral iris roll is very thick or it is anteriorly inserted. Sometimes you can have posterior pushing mechanism primarily related to choroidal expansion or aqueous misdirection. Now, who are the eyes who are prone to angle closure disease? Sometimes they also ask you in your OSCE or something, risk factors. And I think that's very important to remember that women are more prone to angle closure disease, Asians, hypermetropic eyes. Increasing age itself makes you prone to angle closure disease because the lens keeps increasing in thickness, thick lens by itself, shallow anterior chamber eyes, and a family history. What is the role of Von Herrick? So it's important that you know what is Von Herrick and how it is done on the slit lamp. And also you have to know the grading when you're comparing the corneal thickness to the anterior chamber depth thickness, but it has to be done in the periphery of the anterior chamber on the slit lamp with the light and the observation scope at 60 degrees of angle. And as you know that anything less than grade 2 is of concern and risk of angle closure, but just the Von Herrick does not really allow you to make a diagnosis of angle closure till you've not done a gonioscopy. So it's not a substitute for gonioscopy, but just a screening tool. And gonioscopy has been covered today, and it's extremely important that all of us do gonioscopy in each and every case of glaucoma, because we know that the diagnosis of glaucoma itself in the name carries what the angle structures are showing us. So this is just to show you, again, the Von Herrick's. What about the acute angle closure attack, which I said is also caused acute primary angle closure? So these patients present to you with sudden onset pain in the eye, usually unilateral, diminution of vision, headaches and associated vomiting. They can have halos around lights. They'll have epithelial edema on the cornea, shallow anterior chamber, fixed dilated pupil, and the pressures can be very high, sometimes as high as 40 to 70. And of course, you might see the signs of the primary angle closure disease spectrum in the other eye. The other thing they often want to ask you is that what are the investigations utilized to diagnose angle closure disease? And I think the gold standard remains gonioscopy, and that cannot be overemphasized on. And Sheffer grading is something that you all have to be familiar with. And indentation. So now we want to use the indentation gonioscope and not the gonioscope with the viscoelastic, but that very often does not help us identify or differentiate between appositional and synovial closure. So the idea is that you use indentation gonioscope where you can just compress or indent onto the cornea and see dynamically what's happening to the angle, whether the apposition just falls back, the iris falls back, and you can see the open structures without any synechiae, or it's synovially closed. So this helps you identify the pass. Of course, the other tools like ASOCT and UVM have become extremely helpful in picking up, as I showed you, the pathogenesis involved in that particular case and what mode of treatment might be helpful in such eyes. Visual fields will, of course, have to be done, which was covered very in detail, and that is to monitor the stage of the disease and to monitor progression, whether your treatment is helping stop the disease or slow down the disease where it is. Of course, the OCT and the of the optic nerve head and the RNFL is also useful in determining the disease stage and progression. So how do you manage an acute attack? It's basically go all out because the pressures are very high and you need to try and salvage the nerve from the acute damage. So you can give them IV mannitol, oral acetazolamide, topical beta blockers, topical alpha agonists, even topical carbonic anhydrase inhibitors. Pilocarpine can be given too, but pilocarpine will not sometimes affect in the early stages when the pressures are very high. Usually when the pressures come down a little bit and the ischemia in the eyes reduce, the pilocarpine effect starts to show up. There's also a lot of inflammation in the eye, so giving them steroids about 3 to 4 times a day for the first few days can also help prevent synovial pop formation in absolutely early detected acute angle closure eyes. And of course, laser peripheral iridotomy remains definitive. And sometimes, in some cases where the iris itself is so badly plastered that you're not able to relieve or open the angles, sometimes argon laser trabeculoplasty can be helpful. Remember that laser peripheral iridotomy is only going to help you relieve the pupillary block, and it's indicated in all eyes of primary angle closure glaucoma, acute primary angle closure, but in PACS, the suspect eyes, not every eye needs PI. And we will just discuss about one of the studies that has also further enforced this guideline. So we need to identify the high-risk angle closure glaucoma suspects, which are basically eyes which either will be lost to follow-up or are the eyes of where the other eyes had an angle closure disease, which is either glaucoma or PAC. And of course, every fellow eye of an angle closure glaucoma patient needs to be subjected to LPI. You must remember to treat with the laser in the superior quadrant between 11 to 1 o'clock so that the lid can cover the PI and reduce the chances of glare. Avoid 3 and 9, and also make sure the patency is there. Sometimes you get a PI like this, which is lamellar, and that's not really going to do adequate amount of fluid movement to protect against the block. So what is a ZAP trial? I think this is, again, something that you should be aware of, the Zhongshan angle closure prevention trial. What they did over here was it took the patients of primary angle closure suspect eyes, and in one subset, they did the prophylactic laser peripheral iridotomy, and the other subset, they only observed. And they realized that the progression was very, very slow, and the absolute benefit in the eyes which was subjected to the laser PI was not very large. So hence, they recommended that not all eyes of PACS deserve to be subjected to laser peripheral iridotomy. So which are the cases, as I was just talking about it, one-eyed patients, eyes where the other eyes had either a PAC, PACG, or acute angle closure, unable to follow patients, repeated dilations required, let's say a diabetic patient or an AMD patient, positive family history. Now, these are patients where you must do a laser PI. Otherwise, you can choose to follow them up regularly, where the risk of angle closure disease progression is low. What about the EAGLE study, which is the effectiveness of early lens extraction? Now, this again, as we mentioned, that the lens has become critical to the pathogenesis of angle closure disease. So they looked at whether lens removal can be beneficial in eyes with angle closure. So they took patients where the eyes had either a PAC or a PACG and the pressures are above 30 at baseline. They subjected them either to a clear lens extraction or laser peripheral iridotomy, followed by the medical treatment as the routine that we all follow. And they saw that over a period of time, the eyes where the clear lens extraction was done actually did better with the IOP control, with a better quality of life, and also it was cost effective. So hence they started promoting that lens removal does have a good role, although most guidelines recommend cataract extraction, but not clear lens extraction as of now in the management of angle closure disease. In chronic angle closure glaucoma, of course, laser peripheral iridotomy remains the first mainstay of treatment, followed by anti-glaucoma medications. And of course, lens extraction now is a very important tool that we have in the armamentarium for treating angle closure eyes. And of course, trabeculectomy remains the last possible tool in eyes where the pressures are not controlled despite doing all that. MIGS is catching up, which is primarily indicated for open angle eyes. But there are a lot of studies now in published literature and people trying it and talking about it in their presentations, where MIGSs are also being done in eyes with angle closure, where the PI or the lens extraction has opened up the angles for you to be able to play there in the angle. But for the sake of exams and all, I think you'll restrict your talk to open angle glaucomas when you talk about the MIGS. So the take-home message, pupillary block remains the most common cause of pathophysiology of angle closure disease. But there are other non-pupillary block mechanisms that are very, very important, and the treatment modalities now are being diverted towards understanding what is the reason in that particular eye and treat it accordingly. Gonioscopy remains the gold standard. The acute attack of glaucoma is an emergency and should be treated ASAP. And laser peripheral iridotomy still remains the first line of treatment. Early lens extraction is supported by EAGLE, but we are promoting right now early cataract extraction and not clear lens. And not all PACS eyes need the laser peripheral iridotomy, only the high risk eyes. So in the OSCEs, I think you should know how to do a good gonioscopy, how to be able to do a good Von Herix, identify an eye which has had ischemic damage to the pupillary margin due to an acute attack, and have the ability to demonstrate that you can treat an acute attack in the emergency and differentiate various pathogenesis in angle closure disease like pupillary block or plateau iris using anterior segment imaging tools. Thank you and all the best for the exams.
Thanks, ma'am, for your comprehensive presentation. Pranav sir, if you have any comments?
Yeah. I just like to add that there are a few drugs also which can cause acute angle closure glaucoma, especially the topiramate, the sulfonamides, the antidepressants. So the sudden rise in intraocular pressure and myopic shift, that should also cause a suspicion that the patient might be taking some drugs, and that history taking will reveal as to what is the cause of the raised intraocular pressure or the angle closure. So that one aspect also one has to consider, and especially the gonioscopy, what madam said, is absolutely important. Every patient should be subjected to gonioscopy, and a non-invasive Von Herix is also that gives a reasonable amount of information so that you can proceed to gonioscopy. These are things I would like to add.
Absolutely right, sir. I think bilateral angle closure acute attack, you have to always look at secondary reasons, because that is not primary angle closure, but secondary angle closure, very often wrongly diagnosed as primary angle closure. So I think sir rightly so brought that to our notice. Thank you, Ji.
Thank you, sir, for the valuable comment. Next present, I'll be making a next presentation. Okay, is my screen visible? Is my screen visible? Okay, fine. Okay. I'm going to talk about uveitic glaucoma. We have two terminologies. Like uveitic glaucoma, in a patient with uveitis, when the IOP is raised with optic nerve damage and visual field loss, we call it as uveitic glaucoma. It prevalence around 10 to 20% in patients with uveitis. It's another terminology we call as uveitis related ocular hypertension. there is temporary IOP elevation in this patient with uveitis, but there is no optic nerve damage. Its prevalence is around 10 to 46% of the uveitic patients. So, what are the factors which increases IOP in uveitis patients? These are the open angle mechanisms, like increased aqueous viscosity because of the protein levels which is raised during the inflammation. Another thing can be due to pigment deposition or cells or debris or inflammatory nodules in the iridotrabecular angle. Trabeculitis of the, that is inflammation of the trabecular meshwork itself can reduce the drainage and increase the intraocular pressure. And there can be increased trabecular resistance following hypoperfusion in severe cyclitic patients. Corticosteroid also can increase trabecular meshwork dysfunction, in which already the trabecular meshwork is not in a full functional state. And there is cytokines like interleukin-1 and transforming growth factor picta also can affect the trabeculocytes and increase the intraocular pressure. So moving on to the angle closure mechanism, which causes raised intraocular pressure. The inflammatory cells and proteins in aqueous can form peripheral anterior senecae or as shown in the image, or posterior senecae, and it can lead to iris bombay and pupillary block, as which was explained by madam by the previous talk on angle closure glaucoma. And another thing is forward displacement of the lens iris diaphragm can happen due to uveal effusion and a neovascularization of the angle. All these factors can increase the IOP. There are certain factors in uveitic patient which can reduce the intraocular pressure. Like inflammation of the ciliary body can cause decrease of aqueous production, and there can be elevated uveitic outflow due to prostaglandin release. And in 10% of the cases, like hypertony can be seen in juvenile idiopathic uveitis and Fuchs heterochromia cyclitis. So these are the etiology of uveitic glaucoma, etiology and prevalence of glaucoma. In herpes simplex keratouveitis has a prevalence of 10 to 54%, and Fuchs has a 13 to 59%, and Poschner-Schwarzman syndrome has 25% prevalence of glaucoma. So moving on to clinical features, as we said, the IOP can be elevation can be acute in case of herpetic uveitis or Poschner-Schwarzman syndrome, or it can be chronic. What you can see in the cornea, you can see keratic precipitates. In the anterior chamber, you can see cells, flare, and you can see iris nodules. And iris heterochromia can be seen in a Fuchs heterochromia iridocystolitis. In the angle, there can be peripheral anterior senecae, and the lens iris contact posterior senecae can be there. Iris bombay can be there. In this, or other things like in case of BKH, there can be poriosis or vitiligo. So in patient with uveitis glaucoma, you have to see the systemic features also, which is having like rheumatoid arthritis or BKH. You have to see the systemic associations also. Sometimes if you do ultrasound biomicroscopy, you can see a cyclitic membrane, and you have to rule out any traction of the ciliary body. So how will you manage these cases? There is increase in inflammation and glaucoma also. So you have to treat both. First, you have to suppress the inflammation. If you suppress the inflammation, IOP control can be done. How will you suppress the inflammation? Mainstay is corticosteroids. But corticosteroids itself can increase the intraocular pressure. So we have to use it cautiously. You have to differentiate from corticosteroid-induced IOP rise and inflammation-induced IOP rise. Other drug which controls inflammation or can be used in case of steroid responder like cyclosporine, mycophenol mofetil, tacrolimus, azathioprine, methotrexate, and infliximab. Remexolone controls the inflammation with a lower degree of IOP elevation. Like conditions like depot steroid preparations and intraocular steroid containing implants should be used in caution in patients with steroid responder. In certain cases, topical corticosteroids by suppressing the inflammation may actually aid in IOP control. So actually steroid is a double-edged sword, as they say. It should be used with caution. So ocular hypertensive therapy, like what and all we can give. Topical beta blockers remains the first line of agents. Next, prostaglandin analogs can be used, but a risk, only if the inflammation is controlled. There is a risk of inflammation and cystoid macular edema in high-risk patients like pseudophakics or aphakics. So it should be used very cautiously. In chronic uveitis with ciliary body damage, drugs such as dorzolamide or brinzolamide can profoundly reduce the intraocular pressure as already a ciliary body is damaged. Oral drugs like acetazolamide can be used to manage the acute IOP rise, and mannitol and risol are rarely indicated. Drugs like brimonidine and aproconnine are second line of drugs, second line of choice. Pilocarpine is best avoided due to inflammation of the inflammation posterior seneca formation. Mydriatics are used frequently to prevent the formation of posterior seneca. So in case of iris, Bombay and posterior seneca formation, initially they were doing surgical iridectomy and gonioscopy, but now laser iridectomy is being used. Since it is less effective, we have to make because of inflammation, it can close laser iridotomy. So we have to make a large size iridotomy at multiple sites to prevent the spontaneous closure of the iridotomy. So in refractive cases of uveitic glaucoma, unresponsive to maximum tolerable medical therapy, surgery is indicated. Trabeculectomy is the first procedure of choice. Ideally, intraocular pressure should be controlled. Inflammation should be controlled at least 3 months before any surgery. Trabeculectomy with antimetabolites have a better success rate. So when there is cataract and uveitis at the same time, first it's better to do isolated trabeculectomy, trabeculectomy, because it has less inflammation compared to phacotrabeculectomy. The logical sequence for optimal long-term IOP control should be first cataract surgery followed by trabeculectomy, as the cataract surgery will also deepen the anterior chamber. Here, this is a case of uveitic glaucoma with posterior seneca and all. There's a challenge that pupil won't be dilating, so we have to release the adhesion and use iris hooks. And the cataract will be usually soft. It's a complicated cataract. After that, it's IOL is placed. So glaucoma drainage device has better success than trabeculectomy in following cases like uveitis secondary to JIA or previously failed trabeculectomy in aphakic eyes, eyes with prior silicone oil injection, eyes that have had a neovascularization. Destructive procedures like cyclophotocoagulation results in a higher rate of hypertony, so it should be used cautiously. Thank you. Pranav sir, can you give your comments? Sir?
I think he has covered everything very nicely. One thing that whenever you get a uveitic case along with cataract, one has to see to it that the inflammatory reaction to in the anterior chamber is quite at least for a couple of weeks before you undertake any kind of surgery, either a trabeculectomy or a cataract surgery. Right.
Thank you so much, sir. Now over to Dr. Manish for the next presentation.
Thank you so much. Is my slide visible?
Yes, your slide is visible and your voice is audible. You can proceed.
Okay. Thank you so much. So my topic is steroid-induced glaucoma, and thank you so much for the opportunity. Yeah. So steroid-induced glaucoma are open-angle glaucoma, secondary open-angle glaucoma, and steroid in any form can lead to raise in intraocular pressure. So patients who are on steroid, whether it's oral or topical or injectable, we need to monitor the intraocular pressure, because there have been multiple studies which have shown that as high as 30 to 40% of people are steroid responders. The various terms which are used, for example, steroid-induced ocular hypertension basically means patient is on steroid and pressure increases to beyond 21 millimeter mercury. But when it is associated with a disc and field changes representing glaucoma, then it can be called as a steroid-induced glaucoma. Now, in examination, it can be asked that what are responders or how you classify responders. So this is a MLE Becker classification. In this, basically patients are given 4 to 6 week course of topical dexamethasone. If the pressure rise is more than 15 millimeter mercury from the baseline, they are called as high responder. There is another term used for them sometimes is the super responders. If the response is less than 6 millimeter mercury, then they are called as non-responder. And in between 6 to 15 are called as moderate responders. Why it is important? Because we know in India, drugs can be purchased over the counter. A lot of patients use steroids for a long time for allergy, for even for dry eye, irritation. And these drugs are easily available even without prescription. So steroid-related pressure increase is fairly common in our country, but it's a preventable type of glaucoma. If you educate your patient properly, if you give correct prescription that for how many days steroids should be used, we also need to train our technicians, optometrists, even general physicians not to use steroid indiscriminately. And whenever the patient is on steroid, we need to monitor the intraocular pressure. Also, proper history should be taken in every glaucoma patient. Also take the history of alternative medicine. Sometimes patient might be taking homeopathy medicines or some other Ayurvedic medicine also, which might be containing steroids. Even food supplement, protein supplements also often contain steroid, which can lead to raise intraocular pressure. Patients who are predisposed to primary open-angle glaucoma, first degree relative of primary open-angle glaucoma patients are having higher response to steroid. But young children, elderly, high myopes and diabetes, even connective tissue disease patients like patients with rheumatoid arthritis are also predisposed to steroid response. There are also a genetic association which can be asked in the exam, that increased expression of MYOC gene is being seen to be associated with steroid response. Now, why this pressure increase happens due to steroid? What steroid does that it increases the production of extracellular matrix and decreases the destruction of extracellular matrix. And these extracellular matrix, when they accumulate, they decrease the pores of trabecular meshwork. So trabecular meshwork has got small pores. Whenever there is accumulation of extracellular matrix, the pores become narrow, what we call as the clogged filter. So the aqueous is not able to go out. There is a decrease in the outflow. Apart from that, steroid causes stabilization of lysosomal membrane. That also leads to accumulation of glycosaminoglycan and biological edema. That edema also decreases these pores. So basically, there is a trabecular meshwork problem. There is the problem in the outflow of the aqueous. As I mentioned, all types of steroid can lead to increase in intraocular pressure, but most commonly it has been seen with topical steroid. Almost 75% patients are due to topical steroid, but the risk is highest with depot steroids like intravitreal injection and periocular injection. But even reports are there that with intranasal steroid, inhalation steroid, and even skin ointment of steroid, pressure rise can happen in patients who are predisposed to steroids and predisposed to glaucoma. Intravitreal triamcinolone, more than 30% patients will have IOP rise. So whenever you're giving intravitreal triamcinolone, you need to monitor pressure every 2 weeks. If you're using intravitreal implants of dexamethasone, the risk is slightly less. But this particular study, which evaluated 6,000 patients published in BGO, they also shown that as high as 26% of the patient had IOP rise following intravitreal implant. So these patients also need to be monitored for their intraocular pressure. IOP rise generally takes 3 to 6 weeks, but those who are super responder, IOP rise can occur even within days, hours, and 1 to 2 weeks. Once you have stopped the steroid, generally by 2 weeks, the pressure will come down. But in some patients who are predisposed to glaucoma, there can be permanent damage in trabecular meshwork and pressure can still remain high even after stopping the steroid. We also need to classify potent steroid and softer steroids. Sometimes examination you can be asked what are the soft steroids. So loteprednol, fluorometholone, they are softer steroid. They have a lesser chances of IOP rise. But the older steroid like the dexamethasone, even difluprednate and prednisolone tend to give you higher IOP increase. How they present? Like all glaucomas or these patients also similar to primary open glaucoma are mostly asymptomatic, but sometimes patient may come with blurred vision who are on steroid, and when you check the patient, you will see high pressure often associated with corneal edema. So because of this corneal edema, patient can have blurred vision. Patients who are on long-term steroid can also develop cataract, and that also can lead to blurring of vision. Treatment, most important thing, take a proper history, try to find the cause. Sometimes the cause may be hidden under the lids, like this particular patient was not even aware that patient was given a triamcinolone subtenon. So a lot of time during cataract surgery or patient with uveitis are given subtenon injection of steroid, but patient may not be aware. So try to look underneath the lids whether there are any depot steroids. Treatment is first and foremost, we should try to stop steroid if possible. If it is not possible, you can switch to softer steroid or even consider steroid sparing drugs in patients with uveitis or surface inflammation, where you can go for drugs like cyclosporine or tacrolimus or even NSAID if possible. Coming to anti-glaucoma medication, beta blockers like most secondary glaucoma is a drug of choice in steroid-induced glaucoma, but you can also use other drugs like carbonic anhydrase inhibitors, brimonidine, even prostaglandin, ROCK inhibitors, and oral acetazolamide to control the intraocular pressure. These are certain immunosuppressive drugs that also can be used in place of steroids. So if the patient is medically uncontrolled, you have used all the drugs, you can also try going for laser trabeculoplasty. There have been articles which have shown 20 to 30% reduction of intraocular pressure with SLT. Although in my personal experience, I have never used SLT for steroid-induced glaucoma. If the patient is medically uncontrolled, we do consider trying to remove the steroid. If it's a depot steroid, we can go for intravitreal vitrectomy to remove intravitreal steroid, or we can go subconjunctival and remove the subtenon steroids. Trabeculectomy have a fairly good success rate in patients with steroid-induced glaucoma, but in post-op period, you need to use milder steroid and go for quick tapering because that can also lead to raise intraocular pressure. MIGS is coming up in a big way, and we know it has been used a lot in primary open glaucoma, even in angle closure glaucoma also. So if you understand the concept of steroid-induced glaucoma, the problem is primarily in the trabecular meshwork, and there is problem in the resistance at the trabecular meshwork. So those type of MIGS surgery which removes these diseased trabecular meshwork are logically effective. And there have been quite a few articles where they've shown there's GAT or a 360-degree trabeculectomy or even a Cahock dual blade can be used to remove this diseased trabecular meshwork and increase the outflow. So it can be tried in these patients. Before I end, I'd like to share a very interesting case which presented to us a few years back. This was a young lady, 18-year-old, with recurrent pars planitis and cystoid macular edema, and she was treated with oral steroid, topical steroid, and she was also given this subtenon steroid elsewhere, and patient had uncontrolled intraocular pressure. The treating uvea consultant gave her all possible anti-glaucoma medication like timolol, carbonic anhydrase inhibitor, alpha agonist, oral diamox. Still the pressure was 38 millimeter mercury. You can see the Kennicott here. And what was even more important, that patient had already developed cupping. You can see the cupping is already there in the right eye, almost 0.8, and patient also had field defect. So if you have a patient who is on 4 medication with already having field defect and there is cupping, we need to intervene. So how we can intervene in this patient with steroid-induced glaucoma? One option is definitely to go for removal of this depot steroid. Plus, we need to combine some glaucoma surgery also because we need to bring down the pressure really quickly. Trabeculectomy can be done in these cases, but since it's a uveitic eye, generally Ahmed glaucoma valve has a better success rate compared to trabeculectomy in uveitic eyes. Non-valved implant like the RD or the Barvelt or the Ahmed clear path can be used, but they have a slightly higher risk of hypotony. So in this case, we thought we'll go for the Ahmed glaucoma surgery. There is a small video. I'll not go into details of how the Ahmed valve was done, which I think is not the topic of this presentation, but you can see here, this steroid was actually in the subconjunctival space. So we first implanted the Ahmed valve. You can see the valve here. The plate was sutured, the tube was cut and inserted. I like to show how the steroid removal was done, because when you try to remove this depot steroid, especially subconjunctival or subtenar space, it's not easy to remove because there is fibrosis around it and it gets adhered to the adjoining tissue. So once we completed the surgery, we did a subconjunctival dissection and we thought we'll remove this steroid also. You can see here, this was a Kenacort given. If you're trying to remove it, it's difficult to remove because it's already been 2 to 3 months. So we have to cut and remove in pieces this steroid. So you can see here, we are trying to cut the pieces of steroid. You can see the tenons capsule can be seen. So you can't be over aggressive in this case because underneath there is a tenon capsule. And if you open the tenon capsule, then there is a risk of plate erosion. To try to remove as much steroid as possible. And once you have done that, you can close the conjunctiva over it using a 80 Vicryl suture with a round body needle. This is the day 7 post-op. You can see the pressure was well controlled and very minimal amount of steroid was left here. So just to conclude, let's say any patient on steroid in any form, we should monitor intraocular pressure. And whenever you are prescribing steroid, very clearly mention in the prescription for how long patient need to use, and then the patient has to stop it so that you avoid indiscriminate use of steroid. Thank you so much.
Thank you for that wonderful talk, sir. Steroids are now probably more important than most other things in glaucoma because most patients are on steroids for a very long time. I'd like to call Dr. Janani next for her talk on post-traumatic glaucoma.
Thank you so much.
So is my screen visible, sir?
Yes, you can go ahead.
So good evening, everyone. So today my topic is on post-traumatic glaucoma. So does any post-trauma rise in IOP of more than 21 millimeters of mercury, which may be acute or chronic in onset, which occurs after a blunt or penetrating trauma without establishment of glaucomatous optic neuropathy? So the categories of trauma it can be categorized into mechanical injury or others. Under mechanical injury, we have blunt trauma and penetrating trauma, the others being the chemical injury, electrical and thermal injuries, and the blunt trauma being the most common cause of glaucoma. So the mechanism and pathophysiology behind blunt trauma, as you can see, the sudden anteroposterior compression of the globe results in equatorial expansion, which causes posterior displacement of the lens iris diaphragm, which causes the force to transmit along the circumferentially oriented fibers anterior to the equator, which results in 7 rings of Campbell of blunt trauma, which includes sphincter tear, trabecular meshwork tear, iridodialysis, angle recession. Angle recession is tear between the longitudinal and circular muscle fibers of the ciliary body, cyclodialysis, zonulodialysis, and retinal dialysis. So in this picture, you can see sphincter tear, and this picture showing cyclodialysis, this one showing iridodialysis, and this one, this gonio, you can see widening of the ciliary body band. And this picture showing retinal dialysis. So causes of glaucoma after trauma, we can categorize into early onset and delayed onset. Under early onset, we have traumatic iridocyclitis, hyphema related increase in IOP, lens induced, which can be phacotopic because of subluxation of the lens causing pupillary block, and massive suprachoroidal hemorrhage. Under delayed onset, will be angle recession, which I will be discussing. Then angle recession glaucoma, then steroid-induced glaucoma. If the patient was prescribed steroids and he was using it for a longer time, and peripheral anterior synechiae and Gosel glaucoma, which are due to degenerated RBCs after vitreous hemorrhage, which clogs the trabecular meshwork. and retain intraocular foreign bodies like siderosis in case of retained iron particles, and charcosis after retained copper particles, and epithelial ingrowth and fibrous downgrowth after penetrating trauma. So angle recession glaucoma, which is very important. It's a secondary open angle glaucoma which occurs after blunt trauma. It was first described by Collins in 1892. As I already told, it's a tear between the longitudinal and circular muscle fibers of the ciliary body. In this picture, you can see widening of the ciliary body band. And coming to the epidemiology, the frequency of angle recession after blunt trauma is 20 to 94%. And angle recession after traumatic hyphema is 71 to 100%. And not all angle recession develop glaucoma. 5 to 20% of eyes with angle recession develop angle recession glaucoma. And also, as when the degree of angle recession increases, the risk of glaucoma also increases. Like when there is 270 degree of angle recession, then the risk of glaucoma is 5%. While when there is that 360 degree of angle recession, the risk is 24%. And also, we should also know about the bimodal presentation. It's not only it can occur only after 10 years of trauma. The bimodal presentation is it can occur either within 1 year of the trauma, the most common being. The two most common presentation will be one either before the first year of after trauma or at 10 years post trauma. And one more thing, 50% of patients with traumatic glaucoma develop open angle glaucoma in the contralateral eye. This is because those patients will be already genetically predisposed to develop glaucoma, which would have been accelerated by this traumatic insult. And coming to the mechanism of glaucoma and angle recession, it is not the glaucoma does not occur due to angle recession per se. It is due to the proliferative or degenerative changes in the trabecular meshwork, which causes hyalinized membrane on the trabecular meshwork, which can extend onto the Descemet's membrane angle and onto the anterior surface of the iris, resulting in open angle glaucoma. And coming to the relative risk factors, being hyphema, more than 180 degree of angle recession, and high initial IOP, then increased pigmentation of the trabecular meshwork, and lens injury. So lens injury is one of the indicators for severe damage. So it can also be one of the relative risk factor for developing angle recession glaucoma. And clinical features being often the patient will be asymptomatic. And initially the IOP can be normal and patient later will come with unilateral glaucoma. And most of the time the patient does not remember the history of blunt trauma. Whenever we are seeing and we are probing into the history, then patient can tell about the history of blunt trauma. And also it is usually underdiagnosed condition. And gonioscopy, you can see widening of ciliary body band. And optic nerve damage, it usually resembles the like that of primary open angle glaucoma. And gonioscopy, it plays a major role. And usually after acute injury, it's usually deferred for at least 1 week, 4 weeks after that. You can do it after 4 weeks. And you should always compare it with the other eye. And for example, if the patient is one eye, then you can compare with the other angles. And in this picture, you can see widening of the ciliary body band. And other findings can be increased pigmentation of the trabecular meshwork. And here you can see peripheral anterior synec. It can be either localized or extensive. And other findings being glistening scleral spur or absent or torn iris process. Those are the other features. And in ultrasound biomicroscopy, you can see widened angle recess and also posterior displacement of the iris root. And you should always you can compare with the other eye. So this is a normal line and this is a patient with angle recession. And the treatment options being beta blockers, alpha agonists, and carbonic anhydrase, which decrease the aqueous production. And also prostaglandin analogs will also be helpful as it increases the uveous scleral outflow. But in the initial inflammatory phase, you should not give. You should avoid. Later, you can give the patient prostaglandin analogs also. And usually, it is one of the glaucoma which is refractory to medical management. So the indications for surgical management would be progressive optic nerve damage, uncontrolled IOP despite maximally tolerated medical therapy. So the options of treatment would be trabeculectomy with MMC, that is augmented trap, or glaucoma drainage devices. So when should you consider like GDD more than trabeculectomy in case of significant angle damage, prior surgeries, conjunctival scarring, and young patients who are most likely to fail? So in those conditions, GDD can be preferred over TRAB. And coming to the hyphema and glaucoma relation, greater the volume of hyphema, more is the likelihood to develop increased IOP. The grades being grade 1 when it is less than 1/3 of the anterior chamber, grade 2 when it occupies 1/3 to half of the anterior chamber, and grade 3 when it is more than half of the anterior chamber but not occupying entirely. Grade 4 will be total hyphema. So this picture you can see grade 3 hyphema. And the management options would be topical steroids and cycloplegics. And for managing the intraocular pressure, you can give alpha-agonists, beta blockers, and carbonic anhydrase inhibitors, which reduces the aqueous production. And when the IOP is not refractory to topical medications, then you can give the patients oral carbonic anhydrase inhibitors and also hyperosmotic agents. And you should avoid prostaglandin analogs and miotics in the initial inflammatory stages. And you should give the patient a propped up posture. And carbonic anhydrase inhibitors should be avoided in sickle cell disease as it causes acidosis, which can accelerate the sickling. And a surgical intervention like AC wash it should be done when the IOP is more than or equal to 50 millimeters of mercury for 5 days and more than 35 millimeters of mercury for 7 days to prevent optic nerve damage. And also in sickle cell disease, the threshold should be even lower. When the IOP is more than or equal to 25 millimeters of mercury for more than 24 hours, then should surgically intervene. And also presence of corneal staining and rebleeding also surgical intervention, that is AC wash should be needed in those patients. And coming to Gosal glaucoma, it is a secondary open-angle glaucoma which occurs 2 to 4 weeks after the vitreous hemorrhage. Here, the degenerated RBCs migrate into the anterior chamber, clogging the trabecular meshwork, causing increased IOP. Initially, medical management for controlling the IOP. In refractory cases, we should plan for AC wash plus or minus pars-plana vitrectomy. So the take-home message will be comprehensive eye examination should be done to check for the presence of angle recession and other abnormalities after ocular trauma. And the risk of angle recession glaucoma correlates with extent and severity of angle recession and also presence of hyphema. And it is not like a one-time checkup. The patient should be adequately counseled for regular follow-up. Thank you.
Thank you for that very extensive talk on trauma and glaucoma. I'd like to now invite Dr. Nagalakshmi ma'am to talk about neovascular glaucoma.
Well, thank you, Dr. Narayan. At the outset, I would like to thank Dr. Prafulla, Dr. Madhuvanti, and the organizing team for the opportunity. So my topic is, I think, the previous speaker.
Yeah, it's strong.
So my topic is on neovascular glaucoma. Is my screen visible?
Not yet, ma'am. Yes, ma'am.
Yeah.
That's okay.
So as we know, neovascular glaucoma is an important topic from both the exam point of view as well as for our routine practice. So the history dates back to 1906 when it was first described by Cote in a case of central retinal vein occlusion. It is also known by other names like hemorrhagic glaucoma, congestive glaucoma, thrombotic glaucoma, and rubeotic glaucoma. The term, however, was coined in 1963 by Weiss and colleagues. So we are going to just quickly run through the underlying pathogenesis, the stages of neovascular glaucoma, clinical features, management, and look at few case scenarios. So it is a secondary glaucoma which is associated with neovascularization of the iris and or neovascularization of the angle. So the pathology starts with an ischemic retina, which upregulates the pro-angiogenic factors like VEGF, interleukin-6, FGF, and TGF-beta. And there is also downregulation of the anti-angiogenic factors like PEGF. So these diffuse anteriorly into the aqueous, and it stimulates the endothelial proliferation and stimulates the formation of fragile neovascular complex, which results in the formation of neovascularization of the iris and that of the angle. However, these new vessels are not as sturdy as normal vessels, and hence they start leaking. Both the inflammatory cells and the RBCs occlude the trabecular meshwork, resulting in the open angle stage of neovascular glaucoma. This is also associated with fibrovascular membrane formation and contraction, resulting in the formation of peripheral anterior synechiae, which results in the closed stage of neovascular glaucoma. Running through the stages, it starts with the pre-rubeotic stage where the neovascularization is not apparent but can be detected with angiography. The rubeotic stage where the new vessels appear at the pupillary margin and the surface of the iris. And the open angle stage where the vessels and the fibrovascular membrane invades the angle but the angle remains open and the intraocular pressure starts going up. And the angle closure stage, which is the intractable stage where the fibrovascular contraction happens and the peripheral anterior synechiae start forming. This is also associated with ectropia on UVA, where the posterior pigment epithelial cells of the iris starts getting pulled anteriorly. And when the intraocular pressure becomes uncontrolled and optic atrophy sets in, then we have no perception of light, which is called as the absolute glaucoma. So these are some of the pictures which show the pre-rubeotic stage, the rubeotic stage, open angle stage, the angle closure, and the burnt out stage of NVG. So talking about the differences between the normal iris vessels and NVI from the exam point of view. So the normal vessels are usually located in the iris stroma. The arrangement is irregular. The appearance is tortuous. The course is radial. However, the new vessels are mostly found along the pupillary margin. They are irregular, they are thin, they appear in an arborizing pattern. The most important, the differentiating point is that these new vessels at the angle, they do not cross the scleral spur, that is the normal vessels, whereas once they cross the scleral spur, you can confirm the diagnosis of NVA. So this is a picture where you can see that the normal iris vessels are deep stromal and they run a radial course and they are more sturdy in comparison to the new vessels, which are thin, fragile, and they are seen in an arborizing pattern. So Vance's classification of NVA tells the anatomical, based on the anatomical position of the NVI, it is classified as stage 1, where the vessels extend up to the pupillary margin, stage 2, when the vessels go up to the collarette, 3, when it goes up to the angle, and stage 4, when it crosses the scleral spur. So as I told previously, crossing the scleral spur is an important finding which differentiates the NVA from normal angle vessels. So coming on to the etiology, the most common etiology would be proliferative diabetic retinopathy and the ischemic central retinal vein occlusion, both of which contribute about 1/3 to the incidence of neovascular glaucoma. NVG secondary to CRVO is also called as the 100-day glaucoma because most of the incidence happens between the 3rd to the 5th month, where reports also say that it can happen up to 2 years. Other important reason for NVG would be the ocular ischemic syndrome, apart from less common conditions like CRAO, chronic inflammation, neoplasms, radiation, long-standing RD, trauma, and other phakomatosis. So clinical features, generally when, the patient presents with a symptom, it is usually in the open angle stage or the closed angle stage. However, when it is an incidental diagnosis, the pre-rubeotic and rubeotic could be incidental. In fact, they can present with a low intraocular pressure because of poor ciliary perfusion. But when they do present with symptoms, it is a stormy course with a painful red eye, high intraocular pressure, decreased vision, and corneal edema. So it is important that in most of these PDR cases and CRVO, we actually look for NVI. So the diagnosis is essentially clinical. A thorough fundus evaluation is required to clinch the diagnosis and the reason for the NVG. FFA and carotid Doppler helps in narrowing down the diagnosis. Perimetry and OCT helps in grading the severity of the glaucoma. And it is imperative that we perform intraocular pressure and gonioscopy at every visit in these patients to gauge the response to treatment. So when you're presenting a case of NVG, you would like to say that it's a right eye or left eye NVG, which stage of neovascular glaucoma is it, whether it is an open angle stage, closed angle stage, and what is it secondary to. So I'm not going into the details of the clinical features of these 3 conditions. However, one should be aware of the characteristic features on fundus fluorescent angiography of these 3 conditions. So FFA in PDR helps in finding out the neovascularization elsewhere and that of the disc, and helps in closely following up and monitoring these patients for the development of new vessels. And also in ischemic CRVO to find out the CNP areas. And in case of ocular ischemic syndrome, there could be a delay in the choroidal filling in FFA. So carotid artery occlusion usually is a little dicey because sometimes we see these patients with cloudy corneas and you are really not sure about the diagnosis. Very often it is a case of ocular ischemic syndrome where there could be a few deep dot and blot hemorrhages in the mid-periphery and nothing more. So in these cases, doing a carotid Doppler or a CT-MR would help in finding out the carotid occlusion. So other differential diagnosis for NVG in case of an open angle stage would be acute uveitis. Fuchs heterochromic iridocyclitis is an important differential diagnosis. Here, the presence of heterochromic iris, presence of stellate KPs, and absence of neovascularization will help in differentiating it from an NVG. Other differentiating differential diagnosis would be exfoliation syndrome. Again, acute angle closure glaucoma could be a differential when it presents as a closed angle stage. Both come with a stormy course. However, again, the absence of neovascularization helps in differentiating it from NV. So few said before, the stellate KPs, presence of filiform vessels in the angle and Amsler sign, kind of easily confuses it with NVG. So coming on to the management of neovascular glaucoma, it has three main arms. First is addressing the retinal ischemia, which is the most important part of NVG management. Then comes managing the intraocular pressure and inflammation. So PRP, as I told you, is the mainstay for stay of treatment as far as NVG is concerned. So it is done prophylactically in cases with PDR, ischemic CRAO and CRVO and ocular ischemic syndrome, primarily to avoid the incidence of NVG. So the role of PRP would be to destroy RPE so that the oxygen requirement is cut down and it converts hypoxic retina into anoxic retina, thus reducing the stimuli for pro-angiogenic factors. Again, where the media is not very clear, anterior retinal cryotherapy is an option. When you're doing a pars plana vitrectomy with endolaser, you can consider combining it with a endocyclophotocoagulation also in eyes where the media visibility is not great. Gonio-photocoagulation has been described but not very commonly performed. Medical management is again an important aspect of NVG management. The medication is primarily to reduce the intraocular pressure and to keep the inflammation under control. So intense steroids, cycloplegics like atropine, and topical anti-glaucoma medications help in keeping the patients asymptomatic and controlling the intraocular pressure and the inflammation. However, we should keep in mind that pilocarpine and prostaglandins are pro-inflammatory and to be avoided in such patients. Again, as far as surgery is concerned, glaucoma tubes and shunts are a preferred procedure as compared to trabeculectomy, as shown by various studies, especially when it is an angle closure glaucoma. So, but when you're still doing an trabeculectomy, it has to be borne in mind to use a high dose of mitomycin C. Also keep in mind that these patients might have multiple systemic comorbidities and the use of mannitol and acetazolamide should be individualized. High preoperative intraocular pressures in these patients could increase the risk of surgery. So one can consider using pre-placed sutures and do a slow decompression in such eyes. And intraoperative bleeding is again a cause of concern, and that can be mitigated by using intravitreal anti-VEGFs at least 1 week prior to the glaucoma surgery. So in cases where the glaucoma is intractable, the patient has lost vision, the cyclodestructive procedures come into play. So you have the transscleral CPC where the G probe is used 1.5 millimeters behind the anterior edge of the foot plate. Peribulbar block is preferred because the procedure is painful. 180 to 270 degrees are targeted, and we generally avoid the 3 and 9 o'clock procedure, clock positions, because of the presence of long posterior ciliary vessels and nerves. We start with 2000 and then titrate it till a pop sound is heard, and then tone it down. In patients where the limbus anatomy is distorted, we can consider using a light pipe. So micropulse is a recent option where the collateral damage, tissue damage is reduced by the use of micropulses where you have an on time and off time, and only the pigment ciliary epithelium is targeted. So here we usually sweep the area of the ciliary processes. About 5 sweeps is given. and the duty cycle is kept at 31.3%. So the other procedures for these painful blind eyes would be retrobulbar alcohol injection, cyclocryotherapy, and enucleation. These are described in textbooks, but not usually considered these days. Some of the case scenarios, this is a patient who presented with a stormy course and hyphema, cloudy cornea. So here we reduced the intraocular pressure, cleared the cornea, and then looked at the angle. It was an open angle. The cause of NVG was diagnosed to be PDR. Aggressive PRP was done, and steroids and anti-glaucoma medications were initiated. So once the PRP effect took place, the inflammation came down, the patient did settle down without any surgical intervention being required. So this was a patient who came with an angle closure glaucoma stage of NVG. Here, the PRP and medical management was alone not sufficient, so we had to perform a Ahmed glaucoma valve, which was placed in the sulcus in this patient. Because of the PAS, sulcus was adequate and it was non-vitrectomized, so the pars plana was not chosen, and she also did pretty well post the procedure. So this was a patient with intractable glaucoma, NPL. So here the management revolves around the symptoms, elevating the symptoms in these patients. So the treatment algorithm largely depends upon the stage of neovascular glaucoma, the visual potential, and it is usually staged, involving the other specialities as well, and requires a close follow-up. Some of the future therapeutic options would be newer anti-VEGFs we know is always brewing in the market, surgical retinectomy, PDT, vertiporphin to occlude the NVI with intravitreal crystalline triamcinolone are some of the therapeutic options described, and systemic treatment with alpha interferon that inhibits the growth and migration of endothelial cells. Troxarutin where the platelet and RBC aggregation is inhibited are some of the options which have been described in a few papers and textbook. So these are my references and acknowledgements. Thank you for the patient hearing.
Thank you, ma'am, for that really exhaustive and wonderful talk. I'm sure the postgraduates will really benefit. It's usually a theory and a clinical case, so we've covered everything. For want of time, we'll just quickly move to the mainstay of glaucoma surgery, as we call it. One of my seniors and close friends, Dr. Vinod Arnachalam, to talk on trabeculectomy.
Is my screen visible?
Yes, sir.
Thank you, Dr. Praful and Dr. Madhuvanti, for this opportunity. So topic for my day is trabeculectomy. So why trab? Trab is the gold standard procedure. It's a guarded filtration surgery creating an alternative pathway for aqueous drainage from AC to the subcongenital space where it leads to forming a bleb. So what are the indications? So primary open-angle glaucoma, on a maximum medical therapy, we go for a trab. And primary angle closure glaucoma with synovial closure, which is not controlled, IOP is not controlled after LP, laser peripheral iridotomy, we go for a trab. And the secondary glaucomas, pseudo exfoliation and pigmented glaucomas should be also taken into consideration. So a postgraduate have to keep one thing in mind. Among all the glaucomas, pseudo exfoliation is the most fast progressive disease. So we have to be very aggressive in case of a pseudo exfoliation when you treat. Coming to comparison of open angle glaucoma and angle closure glaucoma, pseudo exfoliation is the most progressive and very aggressive one. So we have to treat them very aggressively. So when to go for a trap in other conditions where immediate intervention needed is when you feel progression is noted, and always you have to keep in mind that regular periodical fields test and OCT has to be done so that we can compare the progression has been there comparatively from the previous records. Many places where the fields has been not done regularly. So may keep in mind that regular periodical evaluation of fields is most important one. So the exam point they will ask when you shouldn't do a trap. So when there's active uveitis or when there's a congenital scarring, always lift the upper lid and check whether there's a SACS or a phaco has been done. Because on table when you go and see if SACS has been done, then there's no point of doing a trap. And always check for the congenital scarring and follow-up compliance. Doing a trap is not most important. follow-up is the most important. Doing a trap is easy, where the patient has to come for follow-up. That time, whether pressure is high or low, whether you have to do the suture lysis or release the suture, releasable suture has to be removed, or you have to give a massage. Those things are important. So compliance regarding the follow-up is the most important one. And coming to the very guarded visual prognosis, the macular split or a whiteouts phenomenon. So always look for the macular program when you go for a combined surgery, because it will go for a snuff out phenomenon where the patient may lose the vision post surgery or following a combined surgery. Where it happened to me in one case, from thousands of cases, where wipeout has been happened. So always check for the macular split and tell the patient regarding the guarded visual prognosis before taking them for a combined surgery. So there are types of flaps, fornix based and limbus based. So there's a video of me sharing my video where fornix based flaps been taken. Size are of 5 by 5 by 5 by 4 millimeters. Usually I prefer a triangular flap, and MMC is the most preferred choice by many people. So here you can see with the 15 mm blade, the flap has been raised. The considerable thickness is the most important point we have to keep in mind while doing the flap raise, because it shouldn't be either too thick or shouldn't be too thin. And do a proper cautery so you have the full nice view of the flap. So you have a nice considerable amount of thickness in the tissue. So following a congenital peritomy, a flap is raised. MMC usually kept for 3 minutes. Then thorough wash of the MMC. We do a sclerostomy with a Kelly sponge. And after that, the most important peripheral arectomy has to be done. Always make sure that the iris is not caught into the punch, because it might block the flow. And closing the scleral flap, it's depend upon to various individual to individual. Some prefer fixed and some prefer releasable, where I go by the way of one fixed and with the nylon and two vicryl, so that depending upon the flap size and the conjunctive glaucoma type, I titrate the wound and check for the ooze and then decide. And make sure the flap might have a light ooze, but the conjunctival closure should be like a watertight. So the flap, some people take a rectangular flap and some people take a triangular flap. So the flow depends upon accordingly, and the flow goes and it collects on the conjunctiva, and it has been absorbed by the episkeletal veins. So what are the exam questions mostly in this case, where what determines the filtration, how do you determine the flap tension, when did you go for a suture release, and what would be the wound healing response? So these are the exam based questions. And the post-operative management, usually we give the topical steroids hourly for initial 1 week, then we taper it for 6 times and 4 times, along with antibiotics and cycloplegics. So what should we do on day 1? So every time when we do a trap on table, it will be fine. But when next day, when you see sometimes the results won't be favorable. It might be a flat AC, or it might be high, IOP might be high. So things you should check on the first day of post-operative days, your visual acuity, IOP, AC depth, the blood morphology, and if there is a shallow AC, always check for sedals. So any early intervention, you can make the output even better. So what are the red flags? Red flags are shallow AC when there's hypertony and a flat blood with high IOP. These are the red flags you still seen on the immediate post-ops. So complications can happen in any surgery. The early complications could be the hyphema. When you punch, if you punch beyond over a margin, and if you say ciliary body is there, from there there could be a bleeding. It could have a hyphema. And hypertony can happen in some cases where there's overfiltration. And if it is a very high, very large punch and there's too much of overfiltration happens, it could go for a choroidal detachment. And bleb leak also seen in some cases if they don't go for a watertight closures. And what are the late complications? Bleb failure, encysted bleb. Always make sure that tenons are properly dissected, make way for the posterior flow, and make sure the flow is uniformly unidirectional in all ways. And endophthalmitis can happen, and cataract is also one of the late complications. So how you say is good bleb? There are Moorfield's classification and Wurzburg classification for the exam point of view. Diffuse, elevated, moderate vascular, that depending upon the vascularity, the cyst and encapsulations, those things has been evaluated. And if it is a flat bleb, there's a leak, fibrosis, we have to make it a note, and always check for a Seedles test if there is a hypertony or a very low IOP. So if the bleb is going to fail, what are things you should do? Go for a massage. Ask the patient if there is a high IOP, ask them to come for a very periodical short reviews like for 10 days or 1 week. Give a nice massage so the bleb is elevated, and go for a suture lysis. And the bleb needling is the last option, where in the video you can see a 26 gauge needle has been used. You just go inside and just release the adhesions of the flap. And once you do that, you can nicely see in the video the bleb is being elevated nicely and the flow is being seen very beautifully. So the flat bleb, as you can see, it is gradually, once its adhesions are released, it has been raising from the surface. So bleb needling is better as you intervene as early, shouldn't wait for a longer time, so that the adhesions are not very easy to release. So why was point of question, why is the periphylactic done, and how to differentiate overfiltration from the blood leak. When you will decide on needling, what are the indications for trap in angle closure? And for example, Mr. X on POD1, IOP is 2 and shallow AC, how would you intervene in such conditions? So this might be the exam oriented questions, and wish you all the best. Thank you.
Thank you for that very exhaustive talk, sir. TRAB is still the mainstay of glaucoma surgery, we all feel. But I think our next speaker will always differ with me on that one. He's been speaking all over the world on this topic. Dr. Prasanna, over to you on your favorite mix.
Thank you, Narayanan sir. As I was listening to, I fondly call my glaucoma brother talk about trabeculectomy, and I think had I known, I would have even debated him also in a very friendly banter way. Thank you, Praful sir, Praful Maharana sir, Dr. Madhuvanti, and the whole ophthalmology crash course team for the wonderful opportunity. Next few minutes, the last speaker of the day, I'll try to keep it very short so we can all have a early dinner. And mix in practice, we'll try to have it slightly video based. And I'll be talking about 6-7 mix along with Hydrus, which has recently come. And my journey started in 2019, the quench of thirst towards MIGS, which started in a wet lab in a World Congress. And today, most of my work is on minimal invasive glaucoma surgery. So the total internal reflection in gonioscopy is broken. And in direct gonioscopy, you can see we break it in such a way that we are able to directly see the angle. So that is point number one that the PG needs to know, that the direct gonioscopy is named as direct because you see exactly the way you see the angle, so you are able to perform the surgery. Whereas in indirect gonioscopy, you see it inverted. Rather, whatever you see at 12 o'clock is at 6 o'clock, and left and right will remain the same. Only that 12 will change to 6. So that is why it's called direct gonioscope. You need to know about Copi's gonio lens, which is dome shaped in 2 sizes, especially in the infant and the adult size. We have the Richardson-Schaffer's gonio lens, the Huskin-Barkins gonio lens, which is a prototype surgical lens, Swan-Jacob gonio lens, Torp direct gonio lens, and the Leiden direct gonio lens. So these are all gonio lenses. I'm not going into the theory, but you will be needing these lenses in your recent advances paper, keeping it highly for PG point of view. And these were always there. Mix is not something which has, it is just resurfaced. It is not something which was, something like very novel. It is something that resurfaced with these gonio lenses, which are disposable. iPrism S, iPrism SX, Catina, handled, hand-free, Volk surgical gonio lens, Ocular Secure Flex, HF surgical gonio lens. So these are some of the lenses which are disposable, and my videos are going to be mainly on the TVG lens, iPrism, and the Catina. I have no financial disclosure in any one of the lenses. And you need to know about all these lenses as a postgraduate. How do you go about it? The iPrism SX, iPrism S, which has an anti-reflective technology, which is very good. Whereas the old gonio lens, you can ETO it, it is ETOable, and you can also move it by docking. You can see the clet ring here in the old lens. It has a Thornton style stabilization ring. If you are a person who's going to block the patient with a subtenons or a peribulbar, with the old lens, this is the only lens where you can actually move the eye after you operate under a blocked patient. The Catina lens doesn't have an anti-reflective coating, and the Purkinje image will be a hindrance when you do the mixed surgery. that we have to keep in mind. Again, there is a hand-free Catena lens, which you can use it for both. It's greater flexibility for bimanual surgery, because sometimes if you are a left-handed surgeon, you have to order a Catena lens, which is LH, left-handed. A right-handed surgeon, because you will be doing your gonio in the left hand. So these are some important things. Ocular Secure Flex HF is there. Oculus Gonio Ready is there. So these are all the gonio lenses. The Gonio Ready, as the name denotes, it is attached to the microscope. So your both hands will be free. So let's move to the concepts of MAGS. Once you do your cataract surgery, I do it after I do my cataract surgery predominantly. And then you tilt the microscope towards you 35-40 degrees. As you can see, the microscope has tilted towards me. And then the eyepiece has to be lifted upwards so that it doesn't be pointing down, to avoid neck pain. You lift it upwards. And I also mark a pencil marking so that I don't depend on my assistant, and I can always be sterile, and somebody else who doesn't have an idea, they can just tilt it to the marking that I have done. You can see this is before tilt, the marking is here, and this is after tilt. The marking has now been, this is a pencil marking or the pen marking that I do. And after you do the eyepiece looping. And after that, what you do more is you tilt the patient's head away. The microscope is tilted towards you. Patient's head is tilted 35-40 degrees away. Have the head of the patient above the heart to prevent bleeding when you do the procedure, and that's it. You take this lens. This is a Thornton style stabilization ring, as I told you. This is my preferred gonio lens. You just dock it, and then start using your foot pedal to do the up and down focus, the zoom in, zoom out focus, and you will get the angle. Another thing, again, you can see this is the blocked eye. You can see this is the area where I have blocked, the subtenon's blocked. And once I'm putting the Thornton style TVG lens, I'm able to move left, right, and get good access on either side. 200 degrees of the angle I'm able to view. And that's why I prefer this lens for my mixed procedures. First, you want to start mixed surgery, touch and feel the angle. Take a Sinskey, you go and touch and feel the trabeculum meshwork, how much of three-dimensional stability you have under high magnification. Very important first step. Microscope compatibility checklist should be done, but most of the microscopes are compatible. Make sure your position is slightly obtuse. The angle is obtuse. See the right-hand picture, my dear friends. The angle at the elbow should be obtuse, but in cataract, it will be acute. Your hands will be more close to you in cataract, but in mix, you will have to go more obtuse. The chair also will go behind as the microscope is tilting towards you. The seating position, as I showed, obtuse angle at the elbow, and the right hand appears to be the operating hand, but the left hand is the gonioscopy hand, which is very important, and that is what gives us, the more stable your left hand is, the more easy the surgery will be there. And also the full illumination. Make sure the illumination is full into the microscope so that you are able to avoid loss of light as you are having high zoomed in the microscope. And then also make sure, you put your main incision in such a way that you are able to access both the sides superior-nasally and inferior-nasally. This is not the procedure. I'm just moving the KDB blade on both the sides to show how much of access you have on both the sides. So your incision has to be placed slightly anterior to avoid bleeding as well. And moving on to the procedure, again, it's a very simple procedure. Once you place the gonio lens, what I do is I use the foot pedal to zoom in, zoom out, and I never move the left hand. The left hand should never be moved. And the foot pedal, your left leg should now take over, zoom in, zoom out, fine focus. Once you get the angle, I zoom out. Why I zoom out is I identify the main incision. Now take the instrument inside. And once you take the instrument inside, just one shot, go ahead and do the procedure. So this is excisional goniectomy, called the KDB, where we do the 180-degree ab interno goniectomy on either side. You can see that the goniectomy is done, and that is called KDB. Other few highlights that you need to keep in mind as a neophyte is always when you use a lens which has a scratch, make sure, avoid it. Avoid the disposable lens. If you're going to ETO it for more times, it's going to have a lot of scratches. And as I told you, the Catena lens doesn't have an anti-reflective coating. So the Purkinje image will sometimes disturb you. Excessive pressure on your left hand will also cause a lot of striations, and you won't be able to see the angle well. Again, with the TVG lens, if you are going to give more pressure, the Schlemm canal will collapse. Avoid it. And this is an iStent Inject W case. iStent Inject W, you can see 2 clock hours apart. You just go and click, come back, release, and the stent gets lodged like a bullet. This is a stenting device, and the bleeding is very minimal, and the learning curve is also quite easy. And you don't need to worry about managing blood in these cases. It's quite easy. We just need to, one shot go in, inject, or rather penetrate the trabecular meshwork with the trocar, click, come back and release. But in cases like suture gap, where you need to at least do 20 to 24 throws of the suture, there you need to have the technique to clear the blood. So I personally use a Helon GV Pro. No financial disclosure here, but it is a very good cohesive, and it also not only clears the blood, it forms me the chamber and pushes the iris back, making it a concave configuration, and it gives me good access to thread the suture. This procedure called the 5-0 Prolin, where I make a mushroom tip gonioscopy assisted transluminal trabeculectomy, where you do 24 throws minimum to get the suture on the other side. And you can see the suture has come on the other side, and you do a ab interno ripping out of the Schlem's canal from inside. Gonioscopy assisted transluminal trabeculectomy, where you do an ab interno approach called the suture gap. Again, the blood can not only be inside, it can be between the lens and the cornea. But in high magnification, sometimes we won't be knowing, especially in the early stages, whether the blood is actually inside the eye or outside the eye because you are under high magnification. So again, I'm making the same mistake. I'm clearing the cornea, but not the lens. Again, once, twice. And you can see the outside video now. I'm showing or telling the sister to put saline on the lens and clear the blood on the lens. So whenever there is a blood disturbance, make sure you clear the blood on the cornea and on the lens, and then reassess and go back to your surgery. Now you can see the angle structures are beautifully seen. So this is one of my live surgery videos itself. So once you have mastered this, you can do hands-free technique. You can do all the procedures that I just showed. This is an hands-free technique where you can, do suture gap and even hydrus that is come. So bang is a similar modification to KDB, a similar procedure where there is nothing new to add. Again, KDB we just saw previously. I'm skipping these for want of time. So KDB versus bang and the other procedures are something which are highly debated. One theory what I would want all the PGs to know is bang is not made for this procedure. So you may have some leaflets which can cause PAS. Whereas the KDB procedure was actually made for this where you can have a complete scoop of the whole trabecular meshwork. So that is one point I would want you to take. Hyphema is one complication that can happen, which can be managed conservatively. One bad hyphema I had to do an anterior AAG and just, clear it off. These are some of my work that is well published in literature, and iStent inject is no longer available. I want the PGs to get the point right. iStent inject W is what is available. The flange width has been enlarged. So that is another very important point. Why iStent inject W was in the market is now once you inject it, the stent will not go lost into the canal because the flange is more broader. It's able to get locked and over implantation doesn't happen. And again, these are some of my literature for the same. And these are some of the anterior pictures of the post mix where we have published how the angle actually heals itself. And you can see a clear W sign in KDB. In the B figure, you can see a remnant in the bang picture and a bird B configuration in suture gap may be needed in your recent advances paper. And this is another paper called Skivi, which is due for publication in the next month in the Indian Journal of Ophthalmology, where it shows that suture gap is working well along with iStent inject W. And the next promising alternative is KDB. And last but not the least, ECP is a very upcoming procedure. It also is classified under the mixed conundrum, where you actually selectively cyclomodulate the ciliary processes and not destroy it. So that you need to keep in mind. And there is another theory which is coming in called the compound mix, where you treat the ciliary body and the trabecular meshwork, the area where aqueous humor is actually produced and the area where aqueous humor is actually drained. And I have 16 cases of mine which are showing good results. And the last but not the least, summary of the whole talk. Topical is something I don't really do it. I prefer a peribulbar or a subtenons block, and that is subtenons is my go-to it, and it builds confidence, and also there needs to be no heroic efforts. Subtenons always works well in my hands. Temporal approach till the microscope, till the patient said, high magnification, high intensity light, and choose your lens that you like. Don't need to go about what others are doing. Utilize all the lenses that are available and then make a choice. Mix is not alternation to filtration surgery, as Dr. Vinod sir was telling. Trabeculectomy is still the gold standard, and choose optimal candidates. And mix is doing to glaucoma what anti-VEGF is doing for retina. And these are some of my other publications which are highly cited by stalwarts in the WGW podium, World Glaucoma podium. And these are some of my mixed collaborators. I would like to acknowledge, especially Professor Dr. Tanuj Dada, sir, who has helped me a lot to grow in angle surgery, in academics, as well as in research in angle-based surgery. And I think if I am able to do it, any aspiring PG or a glaucomatologist would be able to do. And again, as I told, I would like to acknowledge Dr. Tanuj, sir. And this is one of my favorite cases where I was the third mixed surgeon in India to do hydrus, the first in Tamil Nadu, where again, this is a very promising implant where similar to suture cat, but you thread the implant with the help of a injector, and that's it. So that is hydrus, which is up and running. So I have trained totally 13 people in mix, and I think it's a very, very nice specialty along with cross-border training as well from Malaysia. So if you guys are looking at it, and if you guys look at mix, want to get trained, I think it's very easy. And it's a very, if you do a trab, mix is nothing for you. It's very easy. So thank you again to the whole team for giving me this opportunity. You guys can catch me at Instagram or on WhatsApp or on mail ID. I would be happy to share all my work as well as clarify your doubts. Thank you.
Thank you, Dr. Prasanna. As usual, fantastic talk, and it was the grand finale. Any comments from anybody for the surgical talks?
I think all the talks were very well covered, and we have overshot the time quite a bit. And all the talks were very exhaustive and they were very detailed. So thank you for all the speakers. We really thank you for participating and patiently presenting everything that is needed for PGs. And now I think we would like to conclude this session. I thank all of you for being here. Thank you so much.